Good morning. Okay. So we are live and ready to get started. This is class 4. We are half done. It's the halfway point. Goes fast. It does go fast. Things get a little easier from this point on because there's not a whole lot that you have to learn. We're going to kind of revisit all of the principles that we've learned and make them into new skills. So for each skill that we're going to learn moving forward, there's going to be parts of it that are going to look very, very familiar to you because we've seen those parts in other skills. Okay. So it actually gets a little easier from this point. Let me see here. Let me go over this way. All right. I just got a comment on my way in this morning on one of my videos. Good morning. On one of my videos on the YouTube channel 20 minutes ago. And this was from Felix Mulinga. This is on the partial bed bath video, which we're going to get to. I took my practical exams this past Saturday, and this skill was one of the skills I had to perform, partial bed bath. Thanks to this channel, I managed to get an 83%. I am now a certified nursing assistant. So congratulations. Okay. So good morning, all. Good morning. Bless you. Bless you. Okay, so you guys had chapter 4 between last class and this class. Are there any questions on chapter 4? Any questions? All right. Did you grade your test? If you didn't do the conversion and know what your grade is, just tell me how many you missed, and I'll do that for you. Ada? You missed 2? Ada, do you have chapters 1, 2, and 3 for me? How many did you miss?
The last class.
Chapter 1. Chapter 1. How many did you miss? 2. Okay. Chapter 2.
Yeah,
2. Okay. Zumarenda. Elvira.
1.
Thank you. Robin.
So I don't have the 4, but I have the first 3.
Okay, that'd be great.
So I missed 3 on the first one.
Okay.
2 on the second one. 3 on the first one.
Okay, very good. Thank you. Samantha.
0.
Thank you. Janaya. Thank you. Catherine. Thank you. Jihu.
3.
Okay. Do you have chapters 2 and 3 for me?
Yes.
How did you do on chapter 2?
Chapter 2.
Page 182.
0.
0.
Chapter 1 is 0.
Chapter 3.
3. 0.
Okay, very good. Thank you. Paula. Thank you. Do you have chapter 3 for me?
2.
Thank you. Kaylee. That's fine. Brianna. Okay, Brianna, can I get 1, 2, and 3 from you? Okay. Okay, thank you. Luz? Kiara? Thank you. Cheyenne? Thank you. Tamika? Jody? Thank you. And Abigail? Okay. All right. So chapter 4 went over body systems, and it was, I don't like chapter 4. I think it's unnecessarily complex for you. And it kind of focuses on the wrong things. You guys aren't nurses. You don't need to know what diseases go with what body systems. It's not really your role. Now, those of you that go on to nursing, you're going to have anatomy and physiology 1 and 2. You're going to have pathophysiology in the nursing programs. You're going to get a lot of that in nursing, but that's not really appropriate for the CNA level. The state is not going to ask you, your patient's had a stroke. What body system does this affect? I mean, that's not really what they're going to ask. So I'm going to go over these body systems with you briefly, and I'm going to explain to you what you do need to know about each body system, okay, for the state exam. So this is going to be a review of what you learned during your homework reading. So we're going to start with the nervous system because that's what controls every other system in your body. This is the big one. This is kind of the master of everything. So your nervous system is made up of your brain, spinal cord, and nerves. We all kind of learned this in 5th grade. This should spark some memory in your head. But we don't really need to know what the nervous system is made up of as a CNA. What we do need to know is what effects of aging will we be seeing in the nervous system? Because remember, half of our job is observation and reporting, right? Half of our job, observation and reporting. Well, how can we report abnormal if we have no idea what normal is? And that's what we're going to concentrate on in this lesson. What are normal signs of aging for each body system? So I want you to think of this like a factory, okay? If I were to invent something, I don't know, we'll invent this pen. If I were to invent this pen and I wanted to have a factory make this pen for me, and I went and toured a couple of factories, and the first one that I toured was 80 years old, rusty, broken down, half of the gears didn't work, and the conveyor belts were all stuck, and it just wasn't very efficient, and it only worked kind of part of the time. And then I went and toured a brand new, state-of-the-art, brand new, everything works perfect factory. Which one do you think I want to produce the best quality pens? The new one, yeah, because everything is working well, right? It's new. Make sense? Well, your body is made up of a whole bunch of different factories. And one of those is your brain, your memory making factory. That's what your brain does. It makes memories, does other things too, but it makes memories. Now, when your brain, when that memory making factory is brand new, the memories it's going to make, good quality memories. They're going to stick around for a very long time because the factory that made those memories was new. Now, the memories that that factory makes 80 years later, yeah, those probably aren't going to be all that great because not everything is going to work as well as it did when it was new. Make sense? Good. So this is why a lot of times with our older patients, they can remember the shoes they wore at a piano recital when they were 12, but they have no idea if they had lunch today. Because the factory that made the lunch memory, it's not working today. Just not online. But the factory that made the piano recital memory, that was a good factory. Those memories are going to stick. So this is why when we're working with older patients, a lot of times they can remember things that happened in the distant past, but they may have trouble remembering what's happening right now, today. Don't get mad at them. It's not their fault that their factory is old. Don't get mad at them. Give them the information they need as many times as they need it. So if they ask, did I have lunch today? Yes, you did. We had Salisbury steak today. Did I have lunch today? Yes, you did. We went to the dining room and had Salisbury steak. So you're going to answer it. You're not going to say things like, I've already told you this. Why don't you listen to me? Make sense? Two different ways of handling that. We want to make sure we're handling it right. So the ability to make memories is going to be affected as we age. Anybody ever walk into a room and can't remember why you went in there? Yeah, well, your factories are aging as well. Okay. So if we do that at our age, imagine what it's going to be like 60 years from now. So we have to have some patience with our patients. I think that's why we call them patients. But the other things that are going to be affected by this nervous system aging are going to be diminished senses, things like eyesight, hearing, smell. Smell is a big one, and smell is going to impact your patients a little bit more than you think it will. Our appetite is linked to both sight and smell. If food doesn't look good to you, you're not going to want to eat it. If food doesn't smell good to you, you're not going to want to eat it. Well, if our sense of smell diminishes as we age and that affects our appetite, what effects do you think that's going to have on our older patients? What kind of appetite do you think they're going to have? Yeah, smaller appetite, diminished, absolutely. So a lot of times in older adults, we really have to work hard to get them to eat because they just may not have that hunger reflex, that the smell of good food that triggers an appetite. You'll also see in a little bit that their stomach volume is going to decrease as well. So they eat a little bit, they're going to feel full. This is why a lot of times older individuals will eat their big meal early in the day and then just have something really small at dinner time. Very, very common as we age. Something else that's going to be affected here is the thirst reflex. Now, this is really important here in Florida because as you age, your thirst reflex diminishes. When you guys get thirsty, you take a drink. And that's what helps keep you hydrated. Your body starts to get dehydrated. It says, hey, we're thirsty. And you go find something to drink to help counteract that, right? Well, that thirst reflex tends to diminish with age. Now, in Florida, we have a lot of heat and a whole lot of humidity. And that tends to dehydrate people pretty quickly. So when we have somebody that doesn't have a good thirst reflex and yet they're in a warm environment, remember we talked about that? Older adults tend to like warmer environments. So if we're in a warm environment and we don't have a good thirst reflex, we could be at risk for dehydration. So with older adults, we have to encourage them to drink all the time. Every time you walk in that room, you should be prompting somebody, did you drink your water? Did you take a sip? Make sure you take a sip for me. Okay. Decreased coordination is going to be very, very prevalent in the adult population. And this is going to couple your nervous system and your muscles. But decreased coordination, very common as we age, which means that if you step on ground that's uneven, your body is able to kind of compensate for that and push you in the right direction so you don't fall. But as we age, that may not, that whole reflex thing may not happen very well. So when we're walking patients, we need to make sure that the ground is nice and level for them because falls happen because of decreased coordination. They're just not able to right themselves very well. Decreased concentration, that's, yeah, I think I've got that now. I think we all suffer a little bit of that because we've got so much stimuli going on all the time. But it's very common as we age to have our concentration level go down a little bit. So you can have a patient who used to sit and look through magazines for like an hour. You could buy yourself an hour by giving them a magazine. But as they age, you realize that, hey, they're not sitting there for an hour. After 15 minutes, they're getting up and wandering again. And that's because their attention span is shortening. It's actually pretty common in the elderly. So there's lots of changes in the nervous system that occur with aging. There's also changes that occur in the cardiovascular system. This is the heart and blood vessels. Now, your heart is a muscle, like any other muscle in your body. If you did bicep curls all day, every day, you would have huge biceps. They'd be super strong. Clearly, I don't do that. But your heart is a muscle, just like your bicep. If you do a lot of cardio activity, your heart's going to get big and strong, like any other muscle. But as we age, we aren't usually hitting the gym. We're spending more time sitting. And that's a lot of times because of the pain of arthritis and decreased stamina and all the things that we're going to talk about here. So if our patient's spending a lot of time sitting, that means that this muscle, this heart muscle, is going to weaken. And that's not going to push around blood as effectively. So your patient may end up short of breath, decreased endurance, maybe have some healing problems because we can't get the good parts of the blood that heal to the areas because our heart just isn't working as efficiently. Now, higher blood pressures, we're actually going to talk about a little bit more later today, but your blood pressure does tend to go up as you age, and that's because your pipes get clogged. It's that simple. We'll talk about that a little bit more. Prolonged bleeding and fragile vein walls, very, very common. Fragile vein walls are a lot to do with that loss of fat layer that protects them. Okay. Starting to see how all this goes together. Boy, after this lecture, you'll realize that getting old is not so fun. Not so fun. Respiratory, your lung volume is going to decrease. You're just not going to be able to inflate your lungs as much. Well, if you can't inflate your lungs as much, that's going to affect your stamina, your ability to do things for a long period of time. If you have to hurry somewhere, you'll probably get short of breath. Decreased lung volume. Shortness of breath, pretty common, especially with any sort of exertion. Endocrine system is going to be affected as we age. This is actually affected pretty consistently. Our endocrine system is our hormone producing system. Now, we tend to think, when we think hormones, we tend to think, teenagers. But you've got a lot more hormones in your body than just teenager hormones. Hormones are actually going to regulate all of your body's processes, all of them. They're the messenger center of your body. So if your brain wants something done, it can't talk to your liver. Your brain and liver do not have a direct line of communication. Your brain cannot talk to your liver. It cannot talk to your feet. It cannot talk to your pancreas. It cannot talk to your kidneys. The brain is controlling everything, but it can't talk to the organs and tell them what it wants to do. It has to send a message. Now, the message that it sends is going to be a hormone. So hormones are going to affect everything in your body, and hormone production is going to slow as we age. So this means that all of those body processes are going to slow down and not be as effective. So your patient's not going to be able to digest food the same way. They're not going to have the same level of alertness. They're not going to have the same level of metabolism that they had before. All of these things are affected by hormones. And of course, the sexual hormones are going to be affected as well. Decreased bone density, that's very common as we age. And again, this is going to be related to those hormones. The brain actually tells your bones, hey, I need more calcium. Break some bone down for me. Mine some calcium from the bones because I need some. You need calcium for your heart to beat at a regular rhythm. Your heart runs on calcium, sodium, and potassium. So if the bloodstream is a little bit low, your brain is going to tell your bones, hey, I need some of your calcium. So decreased bone density can happen because your body is mining calcium. Sleep disruptions, very common in as we age. This actually affects people a lot more than you think it does. When I was young, I could sleep through anything. I still kind of can. I'm still a sleep-in girl. Now, all my best friends, they're up at 5. That's not me. Thankfully, I'm still the sleep-in girl. when we get together and have a girls' weekend, I'm still in bed at 10 a.m. They're up, they've done their day's work, I'm still in bed. So this hasn't really hit me yet. I'm hoping it doesn't. But sleep disruptions are very, very common as we age. Now, I want you to think about this for a second. As caregivers, we tend to, how do I put this? We tend to treat patients like prisoners, and they're not. We're there to help them. They're not prisoners. But a lot of times, CNAs will put patients to bed and then complain when they get up. I put her to bed 3 times and she just won't stay there. Can I get side rails? Well, if she's not staying in bed, why do you think that is? Why do you think that is she getting up just to annoy you? What do you think? What do you think? She can't sleep. Putting her in bed and putting the side rails up, does that help her sleep at all? No, it makes it easier for you. You don't have the right to restrict somebody's freedom of mobility for your convenience. Does that make sense? So much better if this patient won't stay in bed, or if they get up at 3 a.m. and start wandering the hallways, give them something to do. Don't just stick them back in bed because it's easier for you. Okay, good. Good. Urinary system is going to be affected. This is probably the most visible sign of aging that we see, is the urinary system. Older patients have to go more often. Their bladder volume decreases. They just can't hold as much. Their bladder doesn't stretch. Where you used to be able to hold your pee for like 8 hours, 10 hours, you could just ignore your, I got to pee signals and go about your day. As you age, that bladder, it loses its elasticity. It just can't stretch enough. So your patients are going to have to go to the bathroom a whole lot more often. And this is probably the most, the skill that we're going to help the patients with the most. And it can be very frustrating for CNAs because they hit the call light, you walk in there, they say, I got to pee. And you're like, oh my gosh, I just took you 30 minutes ago. What's wrong with you? Well, what's wrong is their bladder isn't able to hold urine. So if they hit the call light 30 minutes from now, help them to the bathroom. Make sense? It's just not able to hold the same amount of urine. The other problem that we have is incomplete emptying. When you pee, usually your bladder will kind of squeeze a little bit to get all the pee out. Okay? As we age, we lose that muscle tone, so the bladder doesn't squeeze to get the rest of the pee out. That means some pee is still left. Well, if some pee is still left and we can't hold all that much, you can see why they're going to be calling you in a half hour. Okay. We also tend to lose the integrity of the valve that holds the bladder closed, and incontinence can occur, especially in women. Integumentary system. This is hair, skin, and nails. This is the most visible sign of aging. We get wrinkles, our hair turns gray, we get age spots. This is something that we can all see. You can see when somebody is getting old. But some things that you may not be aware of is the skin does get thinner and it does dry out. Remember that fat layer we talked about that's under the skin? That also contributes to oil production in the skin. So if we have decreased oil, it means that the skin itself is going to lack moisture. So the best way for me to describe this is with fried eggs. If you take a pan, just a regular pan, not a nonstick pan, and you're going to fry some eggs up, and you just crack your egg and put it in a pan with no oil at all, that egg is not going to be able to flip. It's going to burn onto the pan, right? And it's going to tear. So your yolk goes everywhere. Now, if you put a little oil in that pan, now all of a sudden you can flip the egg, right? It doesn't tear. Well, it's the same thing that happens here. Without that oil production, that skin can tear. So we have to be really, really gentle with our older patients because the skin is likely to tear. And we want to make sure that we're putting lotion on if the care plan calls for it and not skipping it to help lock in some of that moisture so the skin has better integrity. We've already talked about brittle nails. We talked about the decrease in subcutaneous fat. We can see changes in hair color and age spots. Decreased hair production is very common where especially, so men will lose hair and then they grow hair in places that they probably shouldn't, right? So you may have to help an older man trim some hair in their ears just so that they can hear. With females, we generally don't really shave legs because decreased hair production. It's just not as, the hair just doesn't grow as well or as quickly. So you probably won't be helping the patient with that. Reproductive system, of course, is going to change as we age. You guys all went over this in 7th grade health class. Hormone levels reduce. We have menopause in women, which usually results in hot flashes and night sweats, decreased moisture production, decreased fertility. Men also have their own changes of aging as well. This probably doesn't impact CNAs all that much, but the one thing that I do want to talk about is even though hormone levels are decreased, it does not mean they're absent. So be careful with your own interpretation of this. Older adults often still have a sex drive. And if they're in a facility, they may exercise that sex drive with other patients. You would report that to the nurse and then let them handle it. This is not something we want to gossip about or make fun of. We would just report it to the nurse and then let them handle it. But don't make the mistake of thinking they're old, they're not sexually active. That may not be the case at all. If you doubt me, take a trip to the villages. Gastrointestinal system. This is made up of the mouth, esophagus, stomach, intestines, liver, and colon. Again, your digestion is going to slow down. So we're probably going to be eating our larger meals earlier in the day so our body has time to digest it. But the second one there I want to talk about, esophagus muscle tone diminishes. Now, your esophagus is your swallowing tube. That's where food goes down to the stomach. It's a muscle like any other muscle. As we age, it's going to lose muscle tone. Your patient, just because they're older, they're going to be at risk of aspiration or food and fluid going down the wrong tube. So we want to make sure that they're eating slower, taking smaller bites, making sure they have time to chew and swallow before we give them another spoonful. So if you're feeding somebody, we have to know this. Because if we don't know this and we start rushing them to get them to eat fast so we can go feed somebody else, we could actually induce aspiration in our patients. Does that make sense? Good. Constipation, very, very prevalent. And again, it's going to go along with that diminished thirst reflex. If we're not drinking in enough water, then we're probably going to get constipated. We don't absorb the same amount of nutrients that we used to. And again, decreased hunger and thirst reflexes. The musculoskeletal system is bones, muscles, tendons, ligaments, cartilage. We're going to have decreased bone density. We've talked about that. Decreased muscle mass. We've talked about that. Decreased strength. But we also get inflammation in the joints. And this just happens from normal wear and tear. It's kind of like the brakes on your car, right? Just normal wear and tear. You got to replace your brakes every so often because they tend to break down. Well, unfortunately, our joints, particularly our weight-bearing joints, we can't take them to the mechanic and get new brake pads put in. So the patients are usually going to complain of pain and swelling and stiffness in their weight-bearing joints as they age. We call that in arthritis, inflammation of the joints. It can be very, very painful for your patient. So if you're trying to get your patient up and walk them to the bathroom and they're like, oh, no, I can't. I just can't today. don't give them a hard time over that. I mean, this is really painful. Anybody ever slam your finger in a car door? You know how painful that is? That's pretty much what arthritis feels like in the joints all the time. All the time. So it's not pleasant. Instability and coordination impairments, we've already gone over. Lymphatic system, this is our your recycling center of the body. It pulls fluid from where it shouldn't be and puts it back where it should be. This system is also affected. But your lymphatic system is also very, very important in your healing process. There's not much we can do about this. Let me go back here. So when you put all of these systems together and all of the signs of aging together, and we start getting a more complete picture of what our older patients are going to look like, you can see that they're going to need more help than you do. But make no mistake, as you age, these same things are going to happen to you. So we need to use patience with our older individuals. And you need to be aware of these changes so that we can help them more effectively and we can make sure that we're not rushing them or making them feel like they're an inconvenience. Does that make sense? Super important. Super important. We also need to know normals. So if all of these things are normal, then you don't need to report that your patient has to go to the bathroom every 30 minutes. That's normal. Now, if your patient has been holding it for 4 or 6 hours, you're only taking them once or twice a shift, and today they have to go every 30 minutes. Is that a change? What do we do with changes? Report it. So knowing what's normal for aging is important, but also knowing what's normal for the patient. Now, this is where, anybody ever hear of travel CNAs? Almost everybody's heard of travel CNAs. They get paid a whole lot more money to go in and do the same job. And most of you are probably thinking, yeah, I want to be a travel CNA so I can make the money. So let me explain to you something about travel CNAs. Remember that half of our job is observation and reporting. We have to know what's abnormal, not just in general, but also for the patient. If we have facilities full of travel CNAs, there's nobody there that actually knows what's normal for the patient. Can you see how things get missed? Quality of care have decreased significantly since we started this travel, since the pandemic, since we started using travel CNAs. So a lot of facilities have now backed off of travel CNAs and they're just not hiring them. Or, they're not hiring companies that send in travel CNAs. So if you think that you're going to be a travel CNA and you're having trouble finding shifts, this is why. This is why. Facilities are now getting penalized for using too many staff members that don't know the patients because quality of care has decreased. Good. Knowing the patient's normal is just as important as knowing aging normals. All right. Just a second here. So Adriana asks, are we allowed to feed patients? Yes, we are. That will be on next Monday's class. We'll be talking about feeding. So quick review. A pulse is a measurement of how many times the heart beat over 1 minute. To take a pulse, we're going to support the arm. We'll always report it over 1 minute, but how long we count will depend on our care plan. Normal is between 60 and 100. We're going to use our fingertips, not the flat area of our fingers. We're not going to use our thumb to take the pulse. The radial pulse is located on the thumb, the top of the thumb side of the wrist. And we're going to say start and stop for timing. In Florida, we count with 2 evaluators, and this is a documentation skill. When we dress a resident, we're going to remember how to do that by using USA first, undress strong arm first. We're going to ask about clothing preferences. We're going to get our clothing before we undress the patient. We're going to lift from below and support all joints while lifting. We undress the strong arm first and dress the weak arm first. We don't overextend or force movement. We adjust clothing for neatness and appearance. We put the soiled items directly in the hamper, never on the floor. Never on the floor. And call light's going to be in the stronger hands. Hand and nail care. Now, pay attention to this review because we're going to learn foot care in just a little bit. Foot care is hand and nail care, just a little lower. So we're going to support the wrist and arm at all times. We're going to soak the hand in water. Whatever we wash, we rinse. Whatever rinse, we dry. We'll use the beveled edge of the orange stick to clean under the nails, making sure that the hand is supported on a towel, not the table. We'll wipe off that orange stick between nails, use an emery board to file in one direction only. Lotion, wipe off the lotion, and do our closing. Making an occupied bed. Clean rolls toward you, dirty rolls away. So the patient has to be in the middle of the bed at all times. In order to change a sheet, it's easier if they're on their side in the middle of the bed. So we'll use that whole scoot and roll thing to get them on their side. Clean rolls toward me, dirty rolls away. We're going to remain behind, the patient's behind. Remember, you never turn a patient toward you. Smooth out any wrinkles. We're going to make hospital corners. Loosen the sheet over the toes and replace the pillowcase with the opening facing away from the door. A lot of germs out there in that hallway. We don't want those germs to get inside the pillowcase where your patient can breathe them in. Range of motion. CNAs do exercises to retain function, which means that we're only working with what we've got. We're not trying to make it any better. We'll lift extremities from below with a flat palm. 2 points of support at the joints. We'll move slowly and smoothly. Return all the way to the start position. Flexion and extension is up, down. Abduction, adduction is side to side. Rotation is around. So look how much you've learned. We're going to go over 4 skills today. Yep, 4 skills today. We're also going to go over the test registration instructions as well. So a lot to cover today. But thankfully, most of the skills that we're going to learn are similar to something that we've already learned. So it's not, today isn't too hard as far as learning, but remember you are at the halfway point now. All right, so we're going to move on to page 138. All right, when you're looking at page 138, down the side of the page right here, you'll see all of the principles involved in this skill. Again, they're all spelled out for you here, all of the banners. Skill rules, opening, glove rules, barrier, privacy blanket, linen rules, scoot and roll, and closing. We know all these. We've learned all of them. There's nothing new to learn to be able to do this skill. So as far as the principles, we know the things that are going to govern how we do the skill, but we do have to learn the skill's specific steps. So that's what we're going to concentrate on. I have a video for this. At the bottom of the page, you can see test specific information. How long should somebody with your level of experience be able to do this skill in? 8 minutes. Yeah, so you've got 8 minutes to do this skill. We're going to talk about skills timing on Monday. There's a formula that they use to give you the amount of time you have for the test. We're going to go over that in detail, the actual formula they use in the test, and I'll explain to you how they come up with the time. But this 8 minutes is one of the parts of the formula. So they look at how much time they give you for each individual skill. So 8 minutes. All we're doing is turning somebody on their side, putting some pillows to prop them there. It doesn't take 8 minutes to do this. They give you way more time than you need. This is actually a pretty quick skill, as long as you know how to perform it. So this is going to scoot and roll. We talked a little bit about this on Monday. We're going to finish this up today. Of course, we know that you're not going to have side rails in all settings. We talked about that. And we know that we want the patient to scoot toward us before we roll them away. But let's get into this a little bit more as we go through this skill. At the top of page 139, you can see the care plan. Care plan says the resident, position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So, pretty easy care plan. Position a resident on their left side, but we have to provide support. Now, support can be provided with blankets, with positioning aids, with pillows. There's a lot of ways to provide support. But if you remember me saying on Monday, most of our body weight when we're on our side is along our back side. Gravity will always try to pull the patient back onto their back. We have to prevent that from happening because your patient in this skill isn't going to be able to. If gravity starts to pull them onto their back, they're going on their back. So we have to know how to position the patient properly and how to support that position with some sort of aid, whether it's a pillow, a blanket, a positioning aid, or something like that. And that's what we're going to cover today. Now, all of the steps are in here. Supplies are at the bottom. We talked about this on Monday. Side rails are a restraint and require a doctor's order. So just like a crib keeps a baby confined, side rails will keep an adult confined. Positioning rails are not side rails. Those are the top rails. And if we have an immobile patient, they can't move on their own. So that's kind of what this lesson is about. Okay. If you are laying in bed tonight, your body's going to move on its own without you even being aware of it. In the middle of the night, you're sound asleep, your body's going to roll you over. It's going to stretch your leg. It's going to move your arm. Your body moves without your knowledge when you're sleeping. And the reason for that has to do with blood vessel compression. That's really why you're moving. Every part of your body needs a fresh blood supply. Every part of your body. But when you're laying on something, everything above is going to press down. So let's say that my hand, okay, if I lay it on the table and I push down and I put something heavy here, all of that weight is going to push down. So the surface of my hand is what's going to absorb all of that weight. So the blood vessels on the surface of my hand, because there's so much weight above it, are going to get smaller and smaller and smaller and smaller, and they get compressed. Does that make sense? We're going to do a experiment here in just a second so that we can see how this actually works. So when we have a patient that's immobile and can't move on their own, so your body responds to that increased pressure by making you move. If your patient is immobile, they can't move on their own. You can be immobile because of an accident. Right? You break your neck, you are immobile. You can be immobile because of a stroke. You can be immobile because of a severe illness that just makes you too weak to move. A lot of reasons why you might be immobile. But if you are, that means that you can't take care of yourself and somebody else is going to need to do everything for you. But immobility has some other effects as well. It's going to slow digestion. It reduces lung volume. It decreases bone density. It causes muscle atrophy. It decreases immune response. It even affects cognitive function. But one of the biggest organs that's affected is the skin. So when we have patients that are immobile, man, they've got a lot of risk factors. As a nurse, my job is to go in and look at the patient head to toe. I'm looking for real problems and potential problems. All of these are potential problems. And if I have a patient that has a potential skin problem, I've got to come up with something that we can do to prevent that. And that's my job, is to figure out what we can do to help prevent this potential problem from occurring. So one of the biggest issues here with immobility is going to be bed sores. So we have to learn how to prevent bed sores. So let me explain to you how this works. Take one of your hands and put it under your leg. Just sit on one of your hands. You're going to sit on your hand for about 2 minutes now. You're going to want to pull it out. Please don't. Play along with me. It's just 2 minutes. You'll want to pull it out, but please don't. So let me explain to you what's happening here. Your body weight is now on your hand. Okay, it's compressing everything on your hand. And what that does on the inside of the body is actually pretty important. So this compression action that we're talking about it's going to happen everywhere that weight is pressing down on a surface, but it happens more specifically, more higher level of difficulty over bony prominences. So bony prominences is anywhere where your bone has contact with the surface. So the back of your head when you're laying down, right? The back of your skull is pressing on the surface. Your shoulders, your elbows, your hips, the back of your legs, the back of your calves, and your heels. These are all what we call bony prominences, or areas of increased pressure, pushing down. You guys are probably getting a little uncomfortable. This is why. As that bone presses on the muscle presses on the fat presses on the blood vessels, and that presses on the skin. So all of this pressure is moving downward to the lowest level. And the lowest level is always the skin. Well, inside the body, as you have this pressure pressing down, it's going to close off those blood vessels. So now we don't get good blood flow to that area. We're impeding our blood flow. Now, underneath our skin, if we have anything there, wrinkles, hearing aids, food crumbs, anything there, that's going to press up into our skin. So we have pressure from above coming down. We've got these foreign objects pushing up, and the skin is caught in the middle, and it doesn't have good blood flow. So that skin, without good blood flow, pressure from above, pressure from below, is liable to split. That is how a bed sore is formed. Pressure from above, pressure from below, the skin and muscle caught in between. So those tissues actually start to separate. So go ahead and pull your hand out and take a look at it. Take a look at your hand. Do you see color changes? You see color changes? This is only 2 minutes, guys. Look really closely. Can you see the pattern of the chair or your clothing imprinted on the skin? After 2 minutes, that's all it took, 2 minutes, the pressure from below and the pressure from above imprinted your skin. Now, imagine if we left your hand there without moving at all for 8 hours. Those lines are going to get deeper and deeper and deeper and deeper and deeper, and eventually it will cut the skin. So wrinkles on the bed are super, super dangerous. When we're changing an occupied bed, we want to make sure that sheet is just as flat as we can get it, and that there's no crumbs in the bed and no hearing aids and no foreign objects that your patient is laying on. Make sense? 2 minutes. It really only takes about 20 minutes under the right conditions for a bed sore to form. Now, thankfully, that doesn't happen all that often, but it can happen in as little as 20 minutes. In general, when we have an immobile patient, we're going to be turning them every 2 hours around the clock to help prevent this effect. But if your care plan says every hour around the clock, it's because the patient has additional risk factors. So how often do we turn our patients? It depends on the care plan. That's right. So imagine if you left your hand there for hours and hours without moving it. This is why you change position frequently in bed or when you're laying on the couch. Anybody ever lay on your side and your hip gets sore and you have to move? Yeah. Or lay on your back gets sore, you have to move. This is why. It's all about pressure. Now imagine for a second, you're laying on your back and your back gets sore, but you can't move yourself. And yet it's sore. And then it's because you're not moving, it gets sorer and more uncomfortable. It doesn't take long to figure out that this is going to require pain medication at some point because we're not turning the patient very often. Now, pain medication has a whole bunch of side effects that we would rather not have with our patient. So turning your patient frequently, getting them in a much more comfortable position can actually help their long-term overall health as well. You do this on your own, but if your patient can't, then we need to turn them at least every 2 hours around the clock. Remember, this will depend on your care plan, but this is our starting point. Every 2 hours around the clock. In most settings, you'll have something like this. This is called a turning clock. If you don't have one of these, you can make one and put it on the wall. But if you look at this turning clock, you'll see this is the AM clock. So it tells you between midnight and 2 a.m., the patient should be on their left side. Between 2 a.m. and 4 a.m., the patient should be on their back. Between 4 a.m. and 6 a.m., the patient should be on their right side. So I can walk in that room, look at the clock, look at the turning clock, and know exactly where the patient should be. Takes all guesswork out of it. If you don't have one of these, you're allowed to make one. Put it on the wall so everybody's on the same page. But it also lets me know if I look at the turning clock and I look at the patient and it matches, my CNA is taking good care of that patient. If I look at the turning clock and I look at the patient and they don't match, the turning clock says they should be on their left side and the patient's on their back. Who is legally liable for that? Yeah, me. I will hunt you down and find out why. Why is this patient not where they should be? I'm the one that's liable. Good? But this keeps everybody on the same page. Now, when we're turning a patient, we're going to go from their back to their right side, and then 2 hours later, back to their back. 2 hours later, left side. 2 hours later, back to their back. So right back, left back, right back, left back, right back, left back. Never on their stomach. Nowhere on here does it tell you to put the patient on their stomach. And unless the care plan specifically tells you to put the patient on their stomach, we don't. That's because if your patient is immobile, they may not have the strength or the nerves to pull themselves off of their chest cavity for their lungs to inflate. Remember, all that pressure is pushing down. If their lungs can't inflate, they can suffocate. So we don't put immobile patients on their stomach unless the care plan specifically tells you to do so. This is why we don't put babies on their stomach to sleep, because they may not be able to expand their chest cavity. Remember, weight pressing down. Good? So this is where we run into some problems, though, because a lot of CNAs, and well-meaning CNAs, they'll say, oh my gosh, Henry hasn't slept through the night in months, and he says he's so tired. And we're going in there every 2 hours and waking him up. So I'm just going to skip a couple and let him get some good sleep tonight. Well, if you skip a couple, he might get good sleep, but that skin is going to end up breaking down. And he's not going to sleep again for the next year while we try to fix that bed sore, because bed sores are insanely painful. I mean, horrible pain. And they can go all the way down to the bone in a very short period of time. And it can take years to heal. So don't do your patients any favors by letting them sleep through the night. Don't do that. So in order to turn a patient, that's the skill that we're learning, is turning a patient onto their side and propping them there with pillows. In order to turn a patient onto their side, we're going to use that scoot and roll method that we talked about last class. Patient has to be in the middle of the bed after the turn, never at the edge of the bed. And we aren't going to use side rails to keep them safe. We're going to scoot them toward us and then roll them onto their side facing away from us, so that after the turn, they're in the middle of the bed. If we don't scoot them toward us, they get way too close to the edge of the bed. Now, during the test, depending on the person that you're partnered with, because this is a live person skill, you'll be doing this on a real person. And depending on their size, you might ask them to scoot towards you and they only scoot a little bit. And then you roll them on their side and you see that they're pretty close to the edge of the bed. Don't ignore that. Just because you scooted them towards you a little bit doesn't mean that they're in the middle of the bed after the turn. It's not about the scoot. It's about where they are after the turn. Does that make sense? So when you turn a patient, you need to stop and look at them. Are they in the middle of the bed? Because that's what you're being graded on. Is that person in the middle of the bed? If you've got a larger person, that means you got to really scoot them towards you. Now for the test, we can just ask them, hey, can you scoot your body toward me? And they will. In a clinical setting, we might have to move them in segments: legs, hips, torso, shoulders, head. In some settings, we may be able to use a draw sheet. That's a sheet under the patient like a sling. Oh, that doesn't have it. Under the patient that we use as a sling. Now that draw sheet is going to be folded. It's a regular sheet like this, top sheet. You fold it in half lengthwise, long ways, and then you put it under the patient. The folded edge goes under the shoulders. The two halves that join together, the two free edges, are under the legs, about mid-thigh. And we can use that as a sling to move our patient toward us. We also have other things, kind of nifty things like slide sheets. I love these things. They're awesome. They are super, super slippery. They're kind of like a slip and slide without it being wet. You just put it under the patient, and the patient just kind of slides towards you. You got to be really careful with them, though, because they can really slide. The problem with those are that they're insanely expensive. Like one slide sheet, which is like, I don't know, 3 feet by 3 feet. It's small. One slide sheet, it's like $2,500. Insanely expensive. So if your facility has one, I guarantee it's locked up in a supervisor's office, and you're going to have to sign it out and sign it back in and promise your firstborn if you don't. I mean, they're going to keep it under lock and key because, it's expensive. So your facility may not have one. But there's a lot of ways that we can get our patient to the side of the bed before the turn. For the test, we're going to use the easiest one. Just ask them, can you scoot toward me? Okay. Good. So we're going to scoot them towards you so that they're in the middle after the roll. And then after we roll them, we're going to stop and look. Are they in the middle? If they're not, start again. Put them back on their back, scoot them a little closer towards you, and then turn them. But this is what they're looking at on the state exam. It's not the steps that lead up to this. It's where are they after the turn. That's what you need to focus on. This is how we use a draw sheet. If you look here, the draw sheet is underneath the patient. The folded edge is under the shoulders. The two free edges are under the mid-thigh, and then we use it as a sling to pull their body weight toward us. In order to turn a patient, this is really cool. This is really cool. Early in my career, I used to work with bariatric patients, like morbidly obese patients that were trapped in their homes, bedbound in their homes. And I would go in and take their vital signs and see what their complaints were, relay information to the nurse or to the doctors, take their blood, all kinds of stuff, because they couldn't leave the house. And I was working with patients that were 500-600 pounds. Now I'm alone in the house with the patient, and I would have to turn the patient over to clean them up and get the sheets changed and all of that. I can turn somebody that's 500-600 pounds all by myself using the. Now, I'm not all that strong, people. I don't have biceps to kill for. It's all about the proper positioning. If you get the patient in the right position, you can turn somebody that's 3 or 4 times your body weight easily because they're positioned properly. So that's what we're going to learn right now, is how to position the patient to make turning easy, not just on you, but also on them. Because if I take a person like this and try to turn them on their side, I'm going to be like pushing and trying to, because their legs are going to flop back and their shoulders are going to flop back and they're just not going to stay where I need them. So it's going to take me a whole lot of pressure to get them on their side. And it probably is going to hurt them. At the very least, I'm going to bruise them. So we have to learn how to position our patient properly so that that turn becomes super easy on them and us. So when we have a patient, we've scooted them toward us, we're going to turn them on their side. We are going to stand. Remember, after the turn, we remain behind the patient's behind. So we're going to stand on the side of the bed opposite where we're turning them. If we're turning them on their left side, I need to be on their right side. Good? Makes sense? So if I'm turning this patient on her left side, that's her left side over there. If I'm turning her on her left side, I would be on this side of the bed because I always turn her away from me. Now that's important because the side of the bed you stand on is going to affect how you set this up. So you're going to stand on the side of the bed opposite the way we're turning. And then I'm going to take their furthest arm. All right, so I'm standing here. I'm going to take my patient's furthest arm, the one away from me, and I'm going to put it over their head with their elbow bent like this. The closest arm is going to cross their chest like this. Now, when I do that, their upper torso is already kind of moving in that direction. Now I'm going to go down to their legs. The closest knee is going to be bent with their foot flat on the bed. Closest knee is bent, foot flat on the bed. The furthest knee is going to be angled out. So when you get the patient set up like this, okay, everything is now positioned in that direction. And then to turn them, I put my hand on their hip and one on their shoulder, and it's a very easy roll because all of their extremities are already in the right place before the turn. Okay? And this is, if you don't set it up like this, you're really going to struggle with turning a patient. If you do this, and this takes 2 seconds, arm up, arm over, leg bent, leg angled. Arm up, arm over, leg bent, leg angled. 2 seconds. If you do this, the turn is easier on you and them. Okay, good. Questions on this? Is this class for California too? So that's a good question. This class is for all CNAs all over the world because these are all basic nursing principles. These are things that you need to know whether you're in California or Florida or Indonesia, because people are people. So this is something that you need to know no matter where you go. Now, testing standards might be a little bit different. The testing scenarios will be a little bit different, but these principles that you're learning, they are universal everywhere. All right. So once you get that patient positioned for turning, then you just turn them. Hand on the shoulder, hand on the hip, roll them into position. But they're not going to stay like that. You've got to use some pillows to keep them in that position. Otherwise, they're going to roll back onto their back. All of their weight is along their backside. So we're going to put a pillow behind the back in a roll to keep them from rolling backwards. We're going to put a pillow between their legs, specifically between the knees and the ankles. You want to pad those areas. You don't want the knees to rub together. That can create a pressure sore. You don't want the ankle bones to rub together. That can create a pressure sore. And then you're going to put a pillow under that upper arm. So if I got this patient on her side, her arm on top is going to kind of droop down. That puts a lot of pressure up into the neck and the upper back. That can cause muscle spasms, headaches, neck, what we call torticollis, or neck stress. So we want to get that arm in a neutral position. If we put a pillow under the arm and just get it in a neutral position, it relieves all of that pressure. And then we want to adjust the pillow under the head. Now that pillow under the head gets forgotten a lot. We pay attention to the three that we're putting on the bed, the behind the back, between the legs, under the upper arm. But that pillow under the head is just as important. When you roll a patient, remember they've got a pillow under their head when you're starting. When you roll them on their side, chances are their shoulder is going to end up on that pillow. And that scrunches that shoulder up. And now we've got an area of stress. And remember, they're going to be in this position for 2 hours and they can't reposition themselves. So you want to address that pillow, make sure it's just under the head and neck and not the shoulder. And then the call light will go in the bottom arm. Now I'm going to show you a video for this because it has really good close-ups of each one of these pillows. And in the video, you're going to see that I put the call light in the top arm. Don't do that. Put it in the bottom arm. They about 3 years ago, they changed the guidance on that. They want the call light in the bottom hand. And that's because we don't want that call light cord to go across the neck. So the call light's going to go in the bottom hand. Good. So like every skill we do, we're going to follow the care plan. We're going to do our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to turn you onto your side. Is that okay? Close curtain, wash hands, get my barrier, get my supplies. I'm going to decide if I need gloves. If my patient is fully clothed, holding onto all of their body fluids like a champ, I probably don't need gloves. If my patient is in a hospital gown and I'm going to be touching near their privates, I probably need some gloves. Now remember that this skill for you guys is going to be done on a live testing student, one of you. And I assume all of you are planning to go to the test fully clothed. And most of you are probably able to hold on to all of your own body fluids like a champ. So for the test, your patient is fully clothed and holding on to all of their body fluids. Do you need gloves for this skill for the test? It doesn't mean every patient you have will be fully clothed and holding on to all of their body fluids. So remember, this is about the patient, not the skill. Good? Make sense? So I get my supplies. I evaluate if I need gloves. I'm going to put a privacy blanket on the patient because I'm going to uncover them. I'm going to get them to scoot toward me. Arm up, arm over, leg bent, leg angled. Roll them on their side, making sure they're in the middle of the bed after the roll. Put a pillow behind their back. Put one between their legs, one under the top arm, and adjust the pillow under the head. Call light goes in the bottom hand. And then I'm going to take the privacy blanket away and put it into the dirty linen, pull the sheet up, and do my closing. Doesn't take 8 minutes. Plenty of time. Okay. So I'll show you the video for this one because it really does have good close-ups. And then if you need to later, I can help you live.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on that? All right, I had a comment come in just a minute ago that says, is it okay to just know the skill, or do you have to say it word for word like she does it, me, like I do it? And the answer is yes. You have to know how to do the skill, but you also have to talk your way through it for a couple of reasons. And we went over this last week, but it bears repeating. The first reason is your patient has no idea what you're about to do to them. and we're working on their body. You should never put your hands on somebody's body unless they know exactly what your intentions are, especially if they're undressed and laying down, because that's a very vulnerable position. Make sense? The second reason is for the evaluator, because if they're looking at their checklist and they're checking things off, they may not see you do a step, but if they hear it, you can get credit for it. The third reason is for you, because as you're doing the skills, if you say the steps out loud when you're practicing and you say them out loud when you're performing, it will remind you of what the next step is. There's something to that. So when you're practicing this at home, do you remember those gray boxes that if you look at the top of page 138, that gray box at the top of page 138, that's the short version of the skill. It's what's on our flashcards. So those of you that got flashcards, it's this. They're on the flashcards. If you just spend some time reading those gray boxes out loud, read those gray boxes out loud. So supported sideline position, opening. You know, you just go through all the steps, read those steps out loud. And then when you're doing the skill, somebody should be reading those steps to you when you're first doing the skill. That way you know how, you know, what the next step is. You're practicing the right way. You're not developing any bad habits. And then you should be able to do the skill and say the steps out loud. If you can do that for all of these skills before you go test, you will get a perfect score. Perfect score. But it does take a little bit of work on your part. What some of my students did, and they said it was very helpful, is they recorded themselves, audio recording, reading all of the steps. And then when they were in the car, they would just play it. So they kept hearing the steps over and over and over and over again. And it helped them when they went to practice. So, little helpful tip for you. All right. So, for that skill that we just watched, we're going to review it here. We're going to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. Somebody just in the CNA group, I read it this morning, somebody was so mad. I mean, they were so mad that they went and took their test and they failed. And their response, you know, what they posted was, all I did was turn them on the wrong side. I don't understand why I failed. Well, you didn't fail because you turned them on the wrong side. That's actually not why you failed. You failed because you didn't follow the care plan. How important is that care plan? Very. So it's not because you positioned them on the wrong side. It's because you didn't follow the care plan. That's how they see it in grading. You guys see the difference there? Okay. All right. Any questions on that skill? No? Let's move on to foot care. Believe it or not, you already know how to do this skill. You just don't know that you know how to do this skill yet, but you already know how to do this skill. If you look on page 118, you'll see all the principles that are involved in performing this skill. We have skill rules, opening, glove rules, barrier, linen rules, washing rules, basin cleaning, and closing. We know all of those. Nothing new to learn here other than skill specific. At the bottom of the page, you'll see that somebody with your level of experience should be able to do this skill in 13 minutes or less. It is a live patient skill, so you might have somebody do foot care on your foot during the test. And I know most of you are uncomfortable with that. Just close your eyes, go to your happy place, let it be done. Go get a pedicure before, it's a great excuse. But this is a skill. If somebody has it, we have to have a patient for them to be able to demonstrate it on. There's nothing here that's really earth-shattering, but I find this kind of interesting, right? This is a 13-minute skill. They give you 13 minutes to do it. Our last skill, which I think is even harder, they give you 8 minutes. So this skill is we already know how to do it. It's not a hard skill, but it is a little bit of a longer skill because it's a washing skill. And anytime you have washing skills, you've got to go get the water, you've got to check it, the patient's got to check it, you've got to clean the basin and store it afterwards, so it adds time on. So washing skills are always longer than what we call bed skills. Okay. Good. No new principles to learn here. We know everything that we need to know to do this successfully. So let's get into how to do this skill. Along the bottom, you'll see your supplies, and there are a lot of supplies for this skill. There's no way around it. You have to learn supplies. No way around it. You have to learn supplies. You've got to memorize them. So if you have not made flashcards of supplies yet, that's probably going to be pretty high on your list. Go get a package of 3x5 index cards and make your flashcards of supplies and steps so you know what to do. Has all the steps here for you. And our care plan at the top of the page says provide foot care to 1 foot using soap and water. It doesn't tell you right foot, left foot. You get to choose 1 foot. And we don't care why we're not doing the other foot. Not our job, not our problem. We're just going to do 1 foot. But foot care is not what you think it is. We're actually not there to wash the foot. Even though we're doing that, that's what we're doing. We're soaking the foot, washing the foot, rinsing the foot, drying the foot. That's what we're doing, but that's not why we're there. So foot care and hand care look a whole lot alike. With hand care, we supported the wrist and arm at all times. With foot care, we're going to support the foot when we move it. With hand and nail care, we soak the hand in water. With foot care, we're going to soak the foot in water. With hand and nail care, we washed and rinsed and dried. With foot care, we're going to wash and rinse and dry. Now, this is where things kind of change a little bit. With hand care, we cleaned under the nails and filed the rough edges. We don't do anything with toenails. Nothing. We don't trim them. We don't file them. We don't grind them. We don't do anything with toenails. Nothing. But we do look at them. If something looks funny, we need to let the nurse know. Because facilities have a podiatrist or foot doctor that comes into the facility once a month and sees the patients that are on the list to be seen. Now, if you don't do foot care and recognize there's a problem and report it to the nurse, the patient will never get on the list to be seen because that podiatrist does not go room to room and say, you need me? Do you need me? Do you need me? Do you need me? Do you need? They don't do that. They go in, they get a list, they see the patients on the list, and then they leave. So you doing foot care is actually a vital component of daily care for this patient. As we're doing this skill, we're not going to put lotion between the toes. That holds in moisture. We get warm, dark, moist. We're going to inspect all surfaces for wounds, sores, rashes, red areas, anything abnormal, and report those. No bare feet on the floor, so we have to have a barrier on the floor. We're going to put the sock and shoe back on. Now, in a clinical setting, we're going to put new socks on the patient. Clean feet, clean socks, makes sense. But for the test, you're doing this on another student. They're not going to have clean socks in their pocket. So we're going to have to put their sock back on and their shoe. And you'll see that in the care plan. It'll say replace the patient's shoe and sock at the end of the skill. When you put the sock on, make sure you're removing wrinkles. We already talked about how bad wrinkles are. And apply the shoe and secure it. So before we get into this, because this is a long lecture, this is going to take me about 45 minutes to do. Before we get into this, we're going to go ahead and take our break for today. Okay? And then we're going to talk a little bit about diabetes so we can understand why we're doing foot care. So I've got a 5th grade explanation of diabetes for you. So go ahead and take your break, and we'll see you in 15 minutes.
Oh, I'm fine with either one. I don't care. As long as it sweeps out. My ex is spelling. If I was still in high school, I would be doing it all day. And I put an earbud in my ear, listen to music too, see my hair is on me, and hide it on this. Most I did last night. No, if I am on my phone, it's just kind of like in my ear. It already kind of does that unless I'm like staring at it or in the ear. TikTok shop. I mean, it's good for design, but it doesn't. If I kept it in color, it would stay cool. But I just probably my other cup is all oh, that's good. Yeah. I had an angel too, but the thing broke off. Further ago. Yes. So yeah. Yeah. So I mean, I don't.
Have enough of a credit card.
This one was his mom. He's supposed she described my teacher.
Let me go. I'm gonna get that noodle.
After he gets out the day after. I'm not with him anymore. Pero wala ko paggamit sa his best friend. Best friend since they were 8 years old. And yeah. If he does, he never made it known. And I said, because he's schizophrenic and he mind you, this man when I met him was 23 and when I stopped dating him he was 25. Yeah, I started dating him when I was 16. Oh, I taught him how to drive, and he still sucked.
And then you're going into $700
Depende, I did it when I was so I'm not involved in cancer advice. I'm still in the family for greater.
Yeah.
This is what there's more for I mean, depende. Depende. It's so cute. So
This is the Australian Shepherd for
Very easy, I call him.
That's very.
And Ruthie is very excited. He was a really boxer.
Oh, there's one other This case.
He's so cute.
Between Barry and this needs of especially right after school. But the visit schedule the police and you can schedule it to like outside here from 2:40 to 3 and 30. He gets out in 11 days.
Oh, no, he didn't.
Yes, since he's in 3 years, so he was only 3 days. So he doesn't get the vision he needs to see for his days. And then he'll get out of 12 months, he'll get back in the surgery, he'll come back and restart. But if he gets probation, he's gonna have a felony probation. He's not gonna be able to do a lot of stuff. So it's over. Like the introduction of the law enforcement, anything whatsoever, he just. So if he's doing 2 years, he's seeing me. But I'm not gonna have a ring on
Oh yeah, I forgot it's break time. I can go get Jack. I'll be back. Depende.
So right here, this will be today's class. All right. Yeah, they're always right here, so you can always grab them. So for those of you who, if you ever have to leave early or you missed a day or whatever, review sheets are always right there. You'll actually see they're class 1, class 2, class 3, they're all in order. So just grab whatever review sheets you need that you're missing. You just, they're yours. All right. All right, everybody ready? Okay, so we need to understand a little bit about diabetes. So diabetes is an insanely complex condition. People spend years and years studying diabetes, so we're not getting into all of that. What I'm going to give you is a simple 5th grade explanation of diabetes, what happens in the body, and what's happening or the potential complications that we have to watch for in your patients. So that's what we're going to go over now. So we have to talk, when we're talking about diabetes, we have to talk about cells and how, because that really is, diabetes really is a problem with the cells, okay? And a lot of people gloss over that. They think, okay, there's too much sugar in the blood, but it's really, the sugar in the blood is a problem, but the real problem is the cells. So in order to understand that, we kind of have to talk a little bit about metabolism. And again, I'm going to really simplify this to make it easy to understand. So you have a cell, you got trillions of them in your body, and that cell is going to run on sugar. It needs sugar as a fuel source. So that cell tells the brain, I'm starving. The brain says we need to eat. Now, the brain knows that we need sugar to fuel our cells. So usually the brain will trigger a craving that you'll want carbohydrates. So this is all the stuff that tastes good, right? Fries and right, carbohydrates. So you tend to, when you crave foods, you tend to crave carbs. Carbs get a bad rap in our society. Carbs are not bad. Carbs are actually good. Your cells need the sugar that carbs produce. That's not the problem, right? Carbs get a really bad rap in our society. Carbs are, we call it the rule of white. If it's white, it's probably a carb. So bread, rice, potatoes, pasta, flour, anything made with flour. Sugar, anything made with sugar. Now, there are some white things that aren't carbs, but they're kind of few and far between. Most white items are going to fall into carbs. So look at them a little suspiciously. Carbs are not the problem. Excess carbs are the problem. We need a certain amount of carbohydrates for our bodies to run properly. The problem is the American diet is very carb focused, which means that we get way more carbs than we actually need. Now, that's where the problem comes in. Because when you take in more carbs than you need, you can't just excrete out the excess sugar. You can't pee it out. It doesn't go anywhere. It stays. You can't get rid of it. So when you eat a lot of carbs, and the body breaks those carbs down into sugar, whatever isn't used by the cells, the body has to do something with. It can't get rid of it. It's got to do something with it. So in most cases, that excess sugar is put into a box and taped up, and that is called glycogen. And then we put it into a storage unit called a fat cell. So when you eat carbs that aren't being used by your cells, we're going to save them as glycogen in our fat cells for later. Everybody kind of got that? Okay. And that works pretty good to keep your blood sugar levels normal, right? Your cells use what they can. Whatever isn't used is stored for later. Now, the problem with that storage thing is as long as you're using it pretty quickly, it's good. It's a good system, right? You store fat or you store sugar that you're not using right now, but you use it up next week. That works really well. The problem comes in when we put this excess sugar in our storage units and we leave it there for 10, 20, 30 years. Have you ever gone to a storage unit or seen like Storage Wars online where they open up a unit and it's like from 1970 something and there's nothing in there that we can use, right? Because it's all old. Well, that's what happens with your fat cells. That glycogen loses its effectiveness. So your body can't really burn it effectively. And this is why when you have a lot of glucose or glycogen stored in your fat cells, it's hard to get rid of. The longer it's there, the less likely we are to burn it because it's just not good quality anymore. Everybody got that? Make sense? Okay. So that's normal metabolism. That's normal. It's not diabetes. That is all normal. So we have to understand that to understand what's happening with diabetes. So let's talk about that now. So when your body when you eat carbohydrates, your body breaks it down into sugar. That sugar goes into the bloodstream. That triggers your pancreas, which is a factory, to make insulin, a key. Because every one of those cells that sugar has to get into, sugar can't just enter the cell. We have to have a key to open the cell. So you eat carbs, breaks down into sugar. Sugar goes into the bloodstream. Your pancreas produces insulin, which is a key that opens the cell. So this is what it looks like. Cell says, I'm starving. You eat carbs, it breaks down into sugar. Sugar is in the bloodstream. Your body produces insulin. That insulin acts as a key to open the door, and the sugar is able to enter the cell, and everybody's happy. It is a good system, works well. Your cells are no longer starving. They're able to perform the processes they need to perform, and that sugar is being used, not stored. This is a normal system. Where we go off track is when there's no key to open the door. So your cell says, I'm starving. You eat carbs. It breaks down into sugar. Sugar goes into the bloodstream, but it can't get into the cell. There's no way to unlock the cell. There's no key. So the cell is still starving. So you eat more carbs. Those carbs break down into sugar, goes into the bloodstream, but they still can't get into the cell. The cell is still starving. So you eat more carbs. Those break down into sugar, but they still can't enter the cell. So now what we have is a whole bunch of sugar in our bloodstream that has nowhere to go because you can't excrete it. So that's high blood sugar. Good? Make sense? Be a whole lot easier if we could just like get rid of the sugar, but you can't. That sugar is going to build up. Now, this is where our problem lies with diabetes, and that's because of gravity. So with this sugar, have you ever left like a cake or a something on the counter that has like a sugary frosting on it? That frosting gets hard and kind of crystallizes over a couple of days. That is exactly what it looks like in your bloodstream. Those sugar crystals. Sugar is a crystal. It's going to look like this if you magnified it. It is a crystal. Now it's heavy. Crystals are heavy. So when we have this excess sugar in our bloodstream just circulating, because it can't get into the cells and we can't excrete it, it's just going round and round and round. And we've stored everything we can store. We're out of storage unit, so it's just going round and round and round. That sugar, heavy crystal, is going to coat the inside of the arteries. And it's going to make those arteries hard. So now our arteries can't expand when we need more blood. They can't contract if we start to bleed. They're stuck in one position because they're stiff. They're covered in crystals. Now, these crystals are sharp. So they're going to catch everything that floats by, like cholesterol. So cholesterol looks like pizza cheese in your arteries. I mean, it legitimately looks like pizza cheese in your arteries. And as it floats by, it's going to get all tangled up in these sharp crystals. So now you're going to get an ooey gooey mess. These crystals are going to shred cells as they go by. So now we're not carrying as much oxygen where it needs to go because those cells have been shredded. We're not able to heal infections very well because those cells have been shredded. We're not able to stop bleeding very well because those platelets have been shredded. So when we get all of this excess sugar building up on the inside of our arteries, it's going to affect every single part of our body. Diabetes is dangerous. Does that make sense? Good. So when we're born, our arteries look something like this. This is a beautiful artery. Beautiful. I wish my arteries looked like this. They do not. Beautiful artery, wide open. This artery can expand if I'm running around the playground. It can contract if I skin my knee. It does everything perfectly, exactly the way it's supposed to. But our arteries don't stay like this in America. And let me explain why. Let's talk about a 5-year-old kid. They get up at 5 o'clock in the morning. Mom's like, oh no, too early. So mom gives the kid a Pop-Tart, puts him in front of the TV, and just kind of zones out on the couch a little bit until a more civilized hour. So the kid eats a Pop-Tart while they're watching TV. Pop-Tarts are carbs that break down into sugar. That sugar makes the pancreas produce insulin, so the sugar can go into the cells. But we've got a healthy 5-year-old, so the pancreas does what it's supposed to do, produces insulin. Now, about 7:30, 8 o'clock, mom finally says, okay, time for breakfast, and gets the kid a bowl of cereal. Now, kids aren't eating all bran, are they? What do kids eat? Yeah, Fruit Loops, Fruity Pebbles, Captain Crunch, right? All the good stuff. Honey Smacks, right? All the good stuff. Sweet. Those carbs break down into sugar. Sugar goes into the bloodstream. The pancreas is now having to produce insulin. So a little while later, kid needs a morning snack. Good mom, she gives the kid fruit, but fruit is full of fructose, which is a sugar, which makes the pancreas produce more insulin. So the sugar can go into the cells and be used. Lunchtime, national toddler diet of mac and cheese and chicken nuggets. And those are carbs that break down into sugar that make the pancreas produce insulin. Afternoon snack, let's give them a little Debbie something. That's all carbs that break down into sugar and makes the pancreas produce insulin. Dinner tonight is spaghetti and a salad. Kids not going to eat the salad. They will eat the spaghetti, and those are all carbs that break down into sugar and goes into the bloodstream, making the pancreas produce insulin. And then no kid goes to sleep without dessert. So we're going to give them a cookie or something for dessert, which is a carb that breaks down into sugar, makes the pancreas produce insulin. Do you see how hard this pancreas worked in one day? And we keep that diet up for 70 years. And then we get to 70 and all of a sudden our pancreas stops working and we go, well, that's weird. I never had diabetes before. Well, you have diabetes now because you overworked your pancreas. You made it work way too hard and it just gave up. It's out. No more insulin to be had. It ran out. This is why we have a very high rate of diabetes among our elderly population. It didn't happen last week. It started with their diet when they were kids, and we kept up those eating habits through adulthood, and we just wore our pancreas out. Does that make sense? A very, very good ratio for you if you want to keep your pancreas working healthy for the rest of your life. A very good ratio is always eat at least half as many grams of protein as you're eating in carbs. Should be a 2-to-1 ratio. If you do that, right? So I'm not telling you can't have a large fry. Go get a large fry. That's fine. And large fry is about 40 grams of carbs. That means you got to eat about 20 grams of protein to help offset that. Right? That doesn't sound too bad until you realize that's like a half a chicken. Maybe a little more, depending on how big the chicken is. Right? So is that large fry really worth having to eat a half a chicken? Because by the time you eat the half chicken, you really don't have the room for the large fry. So when you do that, when you make your mind do that, like, okay, I can have whatever carbs I want, but I have to eat protein to help offset it. When you make that change in your brain, you will automatically start decreasing the amount of carbs that you eat because it's just not worth having to eat that much protein to offset it. Good. We don't do well when we're told you can't have something. We just don't do well with it. I don't do well with it. Tell me I can't have something and I'm automatically going to want it. Right? That's just human nature. But if you tell somebody, oh, you can have all the carbs you want, go crazy. All the carbs, just make sure you eat half as many protein. And it's like, oh, I got to eat 3 steaks to have that baked potato? Yeah, maybe I don't want the whole baked potato. Make sense? Good. So when we're born, our arteries look like this. This is a beautiful artery. We want to keep this. But when we start eating the way Americans eat, by the time we're in our teens and 20s, our artery looks more like this. There is a reduction in diameter. That second one is smaller than the first. So it's not going to deliver as much blood to the areas that we need blood. So now our muscles are going to get tired sooner. It may not heal as quickly. We may not function as well as we could because our blood vessels have gotten gunk built up in them. Now, if we do the right things, you can live quite nicely with this. I mean, you know, you can live just fine with this. As long as it doesn't get any worse, you're okay. But the problem is that we don't really change our eating habits, right? Our blood pressure here, remember, pressure is the amount of fluid inside this artery. Artery's smaller, so the pressure automatically goes up. That's the first sign of this, is our blood pressures are a little bit higher. Now, if we ignore that and we don't change our habits, we end up with this. How much blood do you think is getting through there? Not as much as it needs to. So we're getting a good buildup of gunk inside our arteries. And the problem is there's no real good way to get this gunk out. Once it's there, it's there. Can't really do much about it. Now, the real problem here is that anytime blood slows down or stops, it clots. So this is slowing down blood. Slowing down blood. Hopefully, we're keeping our heart rate up enough that it doesn't stop and clot. But if we don't do something about this, this is diabetes. This is the beginning stages of diabetes. Your doctor has told you you need to exercise more to keep that blood flowing so it doesn't clot. And you need to eat right. And if we ignore that and we don't change, our blood vessels look like this. That is a clot because that blood has stopped. Clots in our blood system can cause serious damage. We end up with decrease in blood flow to our legs and feet. So now our nerves aren't working right. And we end up with neuropathy. We get decreased blood flow to our eyes, the small blood vessels in the eyes, and now we can't see very well. We get decreased blood vessels to our intestines, so we're not absorbing minerals very well. And now we've got a whole bunch of problems because our blood vessels are gunked up. Now, on planet Earth, we have gravity. Crystals are heavy. So these crystals that are floating around your bloodstream looking for a place to land are going to be pulled downward. What is the lowest point of my lower body? Feet. What is the lowest point of my upper body? Hands. Hand and nail care, foot care. The reason that we're doing these two skills is to look for abnormalities. We're doing this to look at the condition of the skin, make sure that there's no wounds. Now, hands are pretty easy. Patients can usually see their hands pretty well. They can see if there's a problem, but feet are something different because we learned today earlier that as we age, our muscles age with us and we get less bendy, we get less flexible. You might be able to look at the bottom of your feet because you guys are young. As you get older, you get less bendy and you aren't going to be able to see the bottom of your feet at a certain age. You are going to have no idea whether you have a wound on the bottom of your foot because you can't see it. Now, on top of that, feet are usually covered in socks and shoes. So if we have a wound that we're not aware of and our feet are always covered, we can have a wound that doesn't get addressed. That is why we are doing foot care, is to look at the foot. Now, let me explain to you how serious this is. Many, many years ago, I was an agency nurse. Now, this is kind of like a travel CNA. It's a substitute nurse. We go into facilities to cover for their regular staff that has a day off, right? So I don't work at the facility. I don't work with these patients. I don't really know them. And I was on the rehab side. And I got my report. I go in to see my patients, and I walked into one room to see a patient, and all the lights in the room were off. He had one small light right above his bed, one of those small fluorescent lights, but the rest of the lights were off. And as I walk in, I flip on the lights and I say, "Hey, Henry, I'm Patty. I'm your nurse today." And he starts yelling right away, "Turn it off, turn it off." Okay. So I turned the light off and I walked over to the bed and I said, "Is there a reason we don't want the lights on? Do you have a headache or something?" He says, no, I've got diabetic retinopathy and the bright lights really hurt my eyes." Oh, okay, cool. So I'm doing my assessment. I'm talking to him, trying to figure out what's going on with him. And as I'm standing there, I'm getting an odor. Now, if you've ever smelled a wound, it's a very specific smell. And I'm smelling a wound. So as we're standing there, I pull my report sheet out and I'm looking at the report sheet and there is nothing on there about wound care. Crap. So I tell him, now this guy's really gruff. He's in his 50s. He doesn't want to be messed with. He's angry that he's even there. He's just not having a good day. And so I've got to convince him to let me take a look. And I turned on the charm because you can always get further with patients by being nice than being mean. So I turned up the charm, and when I get really sweet, it's really hard to tell me no. So I finally got him to agree to let me take a look. And I looked at all the usual suspects, the things that we just saw a little while ago: the back of the head, the shoulders, the lower back or coccyx area, the back of the legs, the back of the calves. I get down to his feet, and there's nothing on his skin, no wounds. He looks pretty good. But I get down to his feet, and he's got those little slipper socks things on. The socks that have the little dots on the bottom of them, keep you from sliding. And I said, "Henry, can I take your socks off and look at your feet?" And he immediately barked, "No." Okay, there's my red flag. Because if he's telling me no, what do you think he told the CNAs? And nobody reported it. We don't know how long this guy had gone with nobody looking at his feet. We have no idea. But again, I turned on the charm and I got him to finally agree. He had diabetic neuropathy, which means that the nerves of his feet were affected. We're going to talk about that in a minute, how that works. And he just, it feels like, when you sit on your leg for too long and it goes to sleep? That pins and needles feeling? It feels like a million fire ants crawling on you. That's what neuropathy feels like all the time. And if people touch that area, it can be very, very painful. So I get it. I understand. So I explained to him that I really needed to look, and he agreed. And I took the right sock off. And the foot was pretty flaky, needed to be washed, but wasn't horrible. It was okay. Went to take the left sock off, and it stuck to the bottom of his foot. Found my problem. So I go get a big basin of salt water. We call it normal saline, but warm salt water. And I put the whole foot in it, sock and all. We're going to soak it and let it, kind of loosen up. Went and saw some other patients, came back after 20, 30 minutes and went to take that sock off. And as I did, I kind of had to pull a little bit to get the sock to separate from the skin. Like I said, we have no idea how long this guy had gone without anybody looking at his feet. So I had to give a little bit of pressure. So as I did, something went flying past my head. That's not a good sign. So I start counting toes. All 5 toes are there. That's good. So what went flying past my head? One of these. One of these. This is a flat white metal thumbtack. This is not the thumbtack. It was one like this. A flat white metal thumbtack had been embedded in the bottom of his foot. And we have no idea how long. Now, here's the thing. If I had a thumbtack in the bottom of my foot, I would feel it. I would know it's there, and I would have taken it out. But when you have neuropathy, you're not going to feel it. So he had this thumbtack in the bottom of his foot for we don't know how long. But I can tell you it was there for quite a while because the area around that thumbtack was hard, black, dead tissue. Now, we're good in medicine. We can heal a lot of things. We've come a long way since leeches, okay? We can heal a lot of things, but we can't bring dead back to life. Dead is dead. So I know this guy's got a really hard road ahead of him. And remember, he's only in his 50s. This is a bad day. So I called the doctor. I called the wound care specialist. I did wound care. I took my pictures. I documented everything, called the family, did everything I needed to do. And then I left. Not my facility, not my patient. But Henry stayed on my mind. 9, 10, 11 months later, I don't know how long, but it was a long time later, I get assigned back to that facility. And this time I'm on the long-term care side. This is where people live. Remember, short-term is rehab. They're expecting to go home. I'm now on long-term care. I look through my report sheet, and sure enough, there's Henry. That's bad. Oh, that's bad. That means Henry wasn't able to go home. He now lives here. Ooh. So I walked into Henry's room. Hey, I'm Patty, the nurse that found the wound on your foot. How are you doing? And he pulled the sheet aside, and he had to have a below-the-knee amputation. He lost his leg off of it. Lost his leg. So this was particularly tragic for me because it didn't have to happen. If he had had shoes on, where would that thumbtack be? In the shoe. We don't amputate shoes. When we have diabetic patients, they should never, ever, 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 ever be walked without shoes because they are not able to feel injury. They may not know that they broke a toe. They may not know that they stepped on a thumbtack. And in healthcare, we have all kinds of sharp objects that could potentially fall on the floor. We should not, if you won't let a child walk barefoot on the floor, you should not let an adult walk barefoot on the floor. And yet in healthcare, we do this all the time. Anybody ever been a patient in a healthcare? In a hospital? They give you a patient gown and they give you a pair of slipper socks. And you walk all over in those slipper socks. All over. Not thinking at all the fact that your patient or your roommate is on an antibiotic that causes diarrhea and they weren't quite able to get to the bathroom in time. And that ended up on the floor. And you're going to walk through that with those slipper socks. And you're going to get back into bed with those slipper socks on. And all of that patient's pathogens are now in bed with you. Slipper socks are not enough. Ever. Ever. The hospital down here, we aren't going to say the name, the hospital down here has a subway in the lobby. And when I am at the hospital seeing patients and things, often I'll go to the subway to grab a quick lunch, especially if I'm going to be there for quite some time. And every time I'm there, there's always a patient in line at the subway grabbing something to eat with a hospital gown, one on backwards as a robe, and slipper socks. They have walked through that whole facility in slipper socks, and they're going to get back into bed with those socks. Do you know what's getting in bed with them? All of the pathogens. All of them. Now, wounds and incisions are warm, dark, moist, and open. So when you get back into bed with contaminated slipper socks and you have a wound or an incision, you are almost guaranteed to end up with an infection. You guys starting to see that maybe what we have seen isn't the right way to do things? When you get out there and you start working, people are going to tell you, oh, yeah, that's the way you learn it in class, but in the real world, we do things different here. You're going to hear that. You are going to hear that. But I want you to think about that. If that were your mom, would you want her exposed to those pathogens? If you treat your patients the way you would treat your very favorite family member, you'll take excellent care of your patients. Make sense? So when we have a diabetic patient, their feet and their hands are more likely to be affected by this excess sugar. So we've got to pay very close attention when we're doing hand and nail care and foot care. And a lot of times we don't even know that our patient is diabetic yet because they haven't been diagnosed. So this is for everybody. Good? So this is how neuropathy works. You got nerves all throughout your body. And those nerves, just like the inside of the arteries are going to get coated with sugar, the nerves also get coated with sugar. And the best description that I can share with you is if you've ever been up north, we don't have this in Florida, but if you've ever been up north, power lines get covered with ice. And that can actually cause a brownout or a blackout if the ice is severe enough because the signal can't get through the wire. It interrupts the signal. And that's what happens with neuropathy is you've got nerves that are covered with sugar, very similar to this, and the foot might know that there's a thumbtack there. And the foot's trying to tell the brain, hey, we got a thumbtack emergency. Get this thing out of me. But that signal can't make it all the way up to the brain. So the foot knows there's a problem, but the brain, no idea. No idea. So we want to be evaluating our patient's feet generally every shift. Every shift. Now, what we used to do with CNAs, we would tell CNAs, hey, can you just look at the patient's feet every shift for me? You know, whether you're getting them dressed or getting them bathed or putting their shoes and socks on, just take a look at the feet for me. It seems simple, right? Just take a look at the feet. And the CNAs would walk in the room. They go, oh my gosh, this nurse thinks I've got all the time in the world. Yeah, you got feet. I don't know what I was supposed to do with that. Why do I care? Yes, you got feet, right? They didn't understand why they were looking. They just saw it as another task to do. They didn't understand this. So because they weren't actually looking at the patient's feet and wounds were getting missed, we created foot care. That is why you do foot care. It's not to wash the feet. Washing the foot is the reason you're there. Okay, gives you a task to do. But your real objective here is to look at all surfaces of the foot. So during the test, you actually have to say, I'm looking at the feet. Got it? And we should never, ever, ever walk a patient without shoes. Ever. The risk of injury is super high. Okay? So if the patient's feet hit the floor, we got to talk about their shoes. For this skill, you're going to put the patient's shoes on at the end of the skill, and you're going to say, do your shoes fit okay? Or you're going to say something about the shoes. I'm putting your shoes on. You have to say something about you know that that's important. Slipper socks are never enough. We're not going to worry about the rest of these until a later lesson. Okay, so we've got a few things to learn next week about shoe rules. But the first two apply right now. So if the patient's feet hit the floor, we got to talk about their shoes. And for this skill, since we're working with shoes, we're going to talk about them. Slipper socks are not enough. So foot care, now that you know all that, is super easy. It's just like hand and nail care, a little bit lower. We don't do toenails. So we're going to soak the foot in a basin. The basin will be on a barrier. We're going to take the foot out of the basin, supporting it, and put it on a towel to wash it. Remember that we want to wring out washcloths really well. Apply soap to the washcloth, not the patient. We're going to check the water temperature. They're going to check the water temperature. All of those things that we've learned along the way. And then once we've washed the foot, we'll put it back in the basin to rinse it. We'll take it out to dry it. Put lotion everywhere but between the toes. No lotion between the toes. You can get athlete's foot from putting lotion between the toes. And then we'll wipe off that excess, put the shoe and sock back on, making sure the toe seam is where it should be. There's no wrinkles on the bottom of the sock. And put the shoe on and do our closing. That's the whole skill. It's really easy as long as you understand why you're doing the skill. Good? Good. All right, so page 119 has our care plan at the top of the page. It says, provide foot care to 1 foot using soap and water. Let's stop there for a second. The test does not need to see both feet. For the test, if they see you soak 1 foot, wash 1 foot, rinse 1 foot, dry 1 foot, lotion 1 foot, and look at 1 foot, they know you know how to do it. They don't need to see it on the other side. Where does that evaluator want to be? At home, in their pool, drinking their margaritas. They do not want to be watching you wash another foot. You've got it. Thanks. So the care plan is going to tell us 1 foot. Where students go wrong, and I love this, so where students go wrong is they think to themselves, if I do extra, I'll get extra credit. And they start doing things that are not on the care plan, like washing both feet or washing all the way up the leg or doing something crazy. If we don't understand the care plan, we start going off on tangents that we should not be going off. And then we wonder, why did we fail? I don't understand. I did more than what was asked of me. I should have gotten a better grade because I went above and beyond, not understanding that the whole test is about whether you follow the care plan. That's what they're really grading you on. Did you follow the care plan? This care plan says 1 foot, so how many feet are we washing? 1. Resident is sitting in a chair. Their sock and shoes should be replaced at the end of the skill. That's it. That is our care plan. So let me show you this one. I'm definitely going to show you the video for this one. I can't get off the floor anymore. I'm getting old.
Hello,
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. I'm going to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands and apply lotion to all surfaces except between the toes. So I'm going to lift your foot and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There you go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Good morning, Anthea and Miriam. Thank you for joining. All right. Any questions on foot care? Once you know why you're there, foot care actually becomes a very easy skill. Soak the foot, wash the foot, rinse the foot, dry the foot, lotion the foot, and look at the foot. Put the shoe and sock back on, clean up your environment, do your closing. It's not a hard skill to do. For me, the hardest part of this skill is getting back up off the floor, because once I get down there, I'm probably not going to get back up. All right. So now we're moving on to mouth care. All of you know how to do mouth care. You guys all know how to do. You've brushed your own teeth at least once in your lifetime, right? You know how to do this. This is not a hard skill. Make sure the patient is in an upright sitting position. That's important. Wet the toothbrush, put some toothpaste on it, brush what they've got. Let them rinse and spit as often as they need to. And then leave their mouth clean and dry. It's not a hard skill. It's actually a very easy skill. All of the, bless you, all of the principles you need to know this skill, you already know. We follow the care plan. We do our opening. We're going to wear gloves for this because there's body fluids involved. We need a barrier to put our supplies on. We're not going to let the linens touch our uniform. We're going to clean the basin the way we clean everything else. Rinse it, dry it, store it. And we're going to do the closing. So there's really not much here to learn. Mouth care is pretty easy.
Somebody with your level of experience should be able to do this in 12 minutes. Does it take you guys 12 minutes to brush teeth? No. You wet your toothbrush, put some toothpaste on it, 2 minutes. You rinse your toothbrush, you put it away, and you dry your mouth. I mean, does not take 12 minutes to do this. They give you way more time than you need. Now, this is a little bit more complex because we have to do the opening and we have to wash our hands and we have to make sure the head of the bed is up. So it is a little bit more complex, right? There's a few steps in here that we don't have to do for us, but it's not 12 minutes worth of steps. A couple of things with this skill, though, that I do want to bring to your attention. We have to put the head of the bed up, but we can't touch the patient until our hands are clean. When you put the head of the bed up, that pillow that's very comfortable behind their head when they're laying down pushes their head forward when they're sitting up. This is not a safe position for mouth care. So when you put the head of the bed up, we have to put that pillow down behind their back, their upper back, to get them sitting up straight. Well, that means we're touching the patient. You can't touch your patient until you have clean hands. So you're going to do your whole opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to brush your teeth. Is that okay? I'm going to close curtain, wash hands, and then you want to put the head of the bed up. The problem is these controllers, not necessarily clean. So what could I use between my clean hand and the bed controller to keep my hand clean? Paper towel. Absolutely. Good? Questions? So your step-by-step instructions in your book on page 93 will tell you to do your opening and use a paper towel to put the head of the bed up. Unfortunately, the video I still have to update. So I'm actually going to be retaping the videos in November. So all the new videos will be out in November. Or they're going to be they're going to be taped in November. I do all the editing. I do all the production, all the videotaping, and all the editing. So we'll be rolling them out as we go throughout the beginning of the year. But just remember that your book is correct. Okay, book is correct. But nothing really new here to learn. Thank you. Opie, this is your first time on our live. Well, welcome. Vivian says, thanks for the lectures. So educating and elaborate. Good morning, Miss Patty. I appreciate it. Well, thanks for joining us. It's very nice. All right. So no new principles to learn here. Our care plan says a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care, which means we're going to help them with that. Super easy. Excuse me. If the patient has dentures, that is a different skill. We're going to learn about dentures on Monday, how to clean dentures. And dentures does involve cleaning the mouth the dentures came out of. So you'll see mouth care again in that skill. But let's learn mouth care first. So safety first, your patient must be sitting fully upright for this skill. And remember, we want that pillow down behind their back, not behind their head, because we don't want aspiration to occur. Remember, aspiration is breathing in liquids into the lungs. So your step-by-step instructions tells you on step 7 to use a paper towel as a barrier to raise the head of the bed to the full sitting position and then adjust the pillow behind the patient. We're going to put a towel on their chest once we get them in the right position, and that's going to help protect their clothing from any toothpaste. Guys, when you're spitting, when you brush your teeth and you're spitting, you're usually hanging over a sink, so all that stuff's going to go down. When you're sitting like this, all that stuff is going to go right onto your chest. So put a towel there to protect their clothing so they don't get a bunch of toothpaste stains. We always wet toothbrushes before we apply toothpaste. That allows the toothpaste to spread out really well. If you don't wet the toothbrush first, it clumps. And then you got one big clump of toothpaste in one place. And it's uncomfortable for the patient. We're going to brush whatever they got. Top, bottom, front, back, tongue. Brush what they got. Here's a tip. The more toothpaste you use, the more they have to rinse. So we generally, when we brush our own teeth, man, we put this whole great big stripe of toothpaste on there. We use up half the tube and lots of toothpaste. And that's because we're standing over the sink. Whatever we don't need will fall into the sink. But your patient is laying in bed. If you use a lot of toothpaste, they're going to have to rinse and rinse and rinse and rinse. And you'll be standing there for 5 minutes rinsing. Little bit of toothpaste. Generally speaking, a pea-sized amount of toothpaste is all you need to effectively clean your whole mouth. Dry your patient off at the end of the skill. This actually is the most forgotten step on this skill. This is the most forgotten step. Imagine for a second somebody has to brush their teeth and they don't dry your mouth afterwards. So you've got all this spit hanging off of your chin. How comfortable would that be? So take a look at your patient. This is the most forgotten step for this skill. All right. Any questions on this? This is the easiest skill we do, I really think, because it's one you do every single day, or you should. Most people brush their teeth every day. There's not much to learn here. It's only on one care plan set, testing care plan set. So chances of getting this are actually pretty low. You know, it's only on one set. But if your patient needs mouth care, please make sure you're doing it. Let me tell you a story about this. This was awful. I still think about this guy too. This was awful, awful, awful. So there's a young man who was riding a motorcycle, going too fast, hit something, went flying off the motorcycle and hit a tree with his head, and had a kind of a mid-shoulder break. So he was paralyzed from mid-shoulders down. And he was in the ICU for a long time, had a huge brain bleed. This guy, he was in really rough shape, and he was young. He was like 20, 21, young. So he's paralyzed for the rest of his life. This is a bad, bad thing, right? His entire life has changed. So he was in the ICU for a long time. He had a lot of really very serious problems. It was touch and go, weeks, months, he's in the ICU. They were going to be transferring him to a nursing home because his family was working. They couldn't take care of him during the day. So he had to go into a nursing home until they could figure out what they were going to do. So he's getting ready to be transferred to the nursing home, and he ends up in my unit, which was PCU. And so this is kind of an intermediary waiting to go to long-term care. And while he's in there, I noticed that when I asked him, now he could speak, but when I asked him questions, he would give me 1 or 2 word answers, and he always turned his head away. So I'm thinking, this poor kid is depressed. I mean, this is an awful thing to happen to anybody. I would be depressed, this poor kid's depressed. And I'm, going to get a hold of the doctor, get a psych consult and everything. And something else occurred to me, and I can't remember what he did or what he said, but something occurred to me, and I started digging a little bit deeper. And what I found out is the entire time he was in the ICU, nobody brushed his teeth. Nobody. Weeks or months, nobody brushed his teeth. So here he is, right? His body is broken. His life has changed completely, and he's worried about his own dragon breath. I mean, that's not a thing he should be worried about. That is like the least of his problems, but yet it was high on his list of problems to be concerned about, that he knew his breath was horrible. But he also wasn't eating very well, because that film that covers your mouth when you don't brush your teeth can affect your appetite. So he needs protein to heal. He's not eating well. That's going to affect his, there's a whole lot of problems here, right? All because nobody was brushing his teeth. That's horrible. So now instead of a psych consult, I got to get a dental consult. And they ended up pulling several of his teeth. That's what we can do better than that. So if you're caring for a patient and you know they can't brush their own teeth and it's not on the care plan, that's an observation. What should we do with that information? Report it to the nurse. As the nurse, I am still human. When I go in and I do a head to toe assessment on this patient and I look for all real problems and all potential problems and I develop my care plan for you guys to follow, I might be interrupted because somebody fell down the hallway or a doctor called with an order on the phone or a family came up to ask about a lab result. I might get interrupted. And is it possible that I might forget to put something on the care plan because I was interrupted? So yeah, mouth care wasn't on the care plan, but if a CNA noticed that mouth care wasn't on the care plan and nobody's brushing this guy's teeth, they should have spoken up and said, hey, there's no mouth, is it okay for us to do mouth care on this patient? If he had, horrible jaw fractures, no, we don't want you doing mouth care on that. He's got jaw fractures. You could move stuff around. Not good. So it wouldn't have been on the care plan. But what if he didn't have jaw fractures? Nobody's brushing his teeth. So just bring it up to the nurse. Is there a reason we're not doing mouth care on this guy? Make sense? Tell you another one. Oh, this was horrible too. Another young person. She was only like 16, 17. She was really young. Car accident. In ICU for a couple of weeks. Get her in PCU before she's going to go home. And this one was going to go home. But she's like, kept like scratching at her head. And I asked her, do you have a headache or something? Is everything okay? And she said, no, I've got glass in my head. Glass? So she had gone through the windshield. Yeah, in the ICU, nobody picked the glass out of her scalp. Nobody. What kind of care was she getting? I mean, yeah, they kept her alive. That's great. But we've got to remember that there's a human on the bottom of all of this medical. Right? Horrible. We can do better than that. We can. So my job is to remind you about the humanity of what we do and not get wrapped up in the steps. Good? Make sense? All right, let me show you this skill. Aw. My exams are 9/27 in Tampa, and your videos are really helping me a lot. Thank you very much. Well, good luck to you, Miriam. Come back and let us know how you do. I know you'll do fantastic, though. Happy to help. All right. This is a very short, remember you have 12 minutes to do this skill. This is actually a very short video.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. Pretty easy, right? Pretty easy. All right, so we have one more skill to do, and then we're going to go over the test registration process. Sorry, I'm super dry. We should have about a half hour of practice at the end of class today. So I don't give you any practice time the first week and a half because you really don't have a whole lot under your belt yet to practice. But starting today, you'll get a little bit of practice time at the end of class. On Monday, you'll get a little bit more. By next Wednesday, you'll have about an hour at the end of class. The following week, you'll have even more, about 2 hours at the end of class. Remember that you also have this room available to you on Mondays and Wednesdays from 1:30 until 4. Mondays are kind of up in the air right now. I'm not real sure after you graduate whether we'll still have Mondays and Wednesdays, but you definitely will have Wednesdays. Wednesdays won't change. I'm just not real sure about Mondays. But you still have this room available after class until 4. So the best advice I can give you is to practice. If you're not practicing here, make sure you're practicing somewhere. If you're practicing in here, it's best to practice in groups of 3. One person is the patient. One person is the CNA doing the skill. The third person should have your skills book open to that page and read the steps as the skill is being done. That way, if the person being the CNA gets stuck, you can prompt them. You can tell them what the next step is. All 3 people in that scenario learn. The patient learns what it's like to be a patient, but also is watching the steps from the patient's point of view. You're learning the steps. The person performing the skill, obviously learning the steps. The person reading is actually probably getting the most benefit, because there is a link between seeing something performed and reading it as it's being performed that helps cement it in your brain. So the person playing the evaluator or the prompter that's reading the steps is probably getting the most benefit. So practicing in groups of 3 is very, very beneficial. If you don't have 3, if it's just 2 people, then the patient should be reading the steps. If you're at home, practicing on somebody at home, give your patient the book and have them read the steps to you. That way you can be sure that you're practicing the skill right, according to the standards. Okay? So the next skill that we're going to learn how to do is respirations. This is a super easy skill. Oh, I forgot to talk to you about this. A question I get asked a lot is, am I going to have to brush everybody's teeth? Yeah, I know it's kind of icky to brush somebody else's teeth. It's a little weird. Trust me, if your patient can brush their own teeth, they're not going to want you in their mouth. They just aren't going. This is a pretty intrusive skill. Once we get independent, I mean, I don't know any 10-year-olds that say, hey, Mom, come brush my teeth for me. Right? Once you get independent in mouth care, you don't want anybody else in your mouth, even your own mom. It's a little weird. So if your patient can brush their own teeth, they will. You're not going to brush everybody's. So how would we know whose teeth we're going to brush? Care plan. Very good. All right. So respirations is our last skill for today. This is on page 54. There is nothing new to learn here with respirations. We're counting breathing. That's it. We're counting breathing. We're going to count as long as care plan tells us to. We're going to record our readings. Normal is between 12 and 20. You know all the principles. We follow the care plan. We do our opening. We evaluate if we need gloves. And skill-specific stuff we're going to talk about, and then we do the closing. This is a documentation skill. So you will have to do your closing, wash your hands, document, wash your hands. Along the bottom, you'll see a video, and then you'll see that this skill should take somebody with your level of experience 5 minutes or less. Guys, we're counting somebody's breathing for 1 minute. It doesn't take 5 minutes to do, even when you put the opening and closing in, it doesn't take 5 minutes. This is going to be a live testing student. They're going to be laying in bed. Charting is required. Normal is between 12 and 20, and you can be off by 2 breaths in either direction. So let me explain that real quick. Normal is between 12 and 20. Let's say that the evaluator gets 16. If you get 14, 15, 16, 17, or 18, you are considered accurate. Normal's between 12 and 20. I mean, there's just not much. It's almost the entire range that they give you for accuracy. Do you guys see that? Okay. So don't be too concerned about the number that you're getting here, but I do want you to learn how to measure respirations appropriately. Now, this does have a little bit higher degree of complexity than pulse. And the reason is because you've got to time this using a clock. So for respirations, we're watching their breathing, but we also have to look at the clock. So how do you watch their breathing and look at the clock at the same time? So that gets a little bit confusing for students. So I want you to see how long does it take me to do 1 breath in and out. So take a look at the clock. It's a long time. At least, 4 or 5 seconds, right? Do you think that you can glance from me to that clock and back in 4 or 5 seconds? Let's give it a try. Look at me. Look at the clock. Look at me. So in the time it takes me to, you can look at the clock and back. Does that make sense? Okay. All right. So we're going to learn skill-specific steps. Our care plan at the top of the page, on page 55, says the patient will be lying in bed for the skill. Count the patient's respirations for 1 full minute and record your reading. So the first thing that we have to understand is that we can't tell the patient that we're counting their breathing. If you do, if I say, I'm counting your breathing, ready, go, right? People will stop breathing because now they're aware of it, and it will alter their breathing patterns. We're not going to get anything accurate if we tell them we're counting their breathing. So when you are going to do this skill, it's actually not going to look like you're counting their breathing. It's going to look like you're taking their pulse. So you're going to hold their wrist. I'm not finding the pulse. I'm just holding their wrist, but they don't know that. The other reason that we want to do that, let me reposition this camera real quick. I need a volunteer, somebody over in that. Here. 79. Okay. See if I can get that a little lower. Hold on a second. There we go. Okay. All right. So let me show you why this is so creepy. If I'm going to count her respirations, and I've done my whole opening, knock, 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 hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to get your vital signs, because remember, we don't want to say breathing. I'm here to get your vital signs. Is that okay? Close curtain, wash hands. Right? So now I'm over here, and I'm ready to count her breathing. If I just stand over her, silent, and don't touch her, look how creepy this is. How comfortable are you right now? Not at all. Yeah, she's like, stop. Okay, you cannot just stand over somebody and stare at their chest for a full minute without them getting creeped out. You just can't. So when you do this skill, you're going to say you're counting their vital signs, and you're going to hold their wrist like you're taking their pulse. So if I, your wrist here. So if I do this, now her focus is here, even though she knows that I'm taking her respirations, right? Because she's a student and I've just had this whole lecture, right? She knows, but this is more comfortable for her, isn't it? Isn't that weird? Isn't that weird? So when we're taking vital signs, particularly measuring respirations, you want the patient to be relaxed. You want them in what we call a neutral state so that we can get an accurate reading. If we make them anxious, that's going to elevate their heart rate and their breathing rate, and we're not going to get an accurate result. We need them in a neutral state. Make sense? Okay, so breathing in and out counts as one. Stay there for me. Oh, I'm sorry, guys. Hold on. I'm sorry. I know you probably can't hear me. Sorry. Okay. Let me try this again. In and out counts as one. So that's one. That's two. Okay. In and out counts as one. So it doesn't matter whether you are starting the count on the inhale, at the peak, or on the exhale. It doesn't matter where you're counting. The whole thing counts as one. So if you start counting and the patient is exhaling, it counts. Make sense? Okay. So in and out counts as one. Our care plan is going to tell us to count for 1 full minute. And because the care plan says to count for 1 full minute, that's how long we're going to count for, 1 full minute. But if the care plan doesn't specify, we can do the same thing we did for pulse. we can count for 15 seconds, multiply that by 4 to get our full minute reading. I'm going to tell you that there's a way to make this skill way easier on you, way easier. So I want everybody to take, I know it's going to be a little weird, but just bear with me. I want everybody to take a look at her tummy and watch her, see if you can see her tummy go up and down as she's breathing. Right? Just take a look, see if you can see her tummy go up and down. If I can get you to put your arm at the side for me. Yeah, you can kind of see your tummy go up and down, right? But it's probably hard for you guys way back there to see it. So I just need to put that there for a second. Now, can you see her tummy go up and down? Over there, can you guys see it? So I did not change her breathing. What I did was change your ability to see it. I used psychology. Because our eyes are drawn to movement when it's a contrasting color. This is what kept us safe in the, saber-toothed tiger days. If you see a contrasting color that's moving, it'll draw your attention. So that's what I'm doing here. I'm putting an alcohol pad on her tummy, and that's going to help me visualize her respirations. It makes it easier. It also keeps those evaluators on the other side of the room, not hanging over you, because now they can see the respirations from far away as well. So remember, in and out counts as 1. Doesn't matter where you're counting. The inhale, the top, the exhale, doesn't matter. We're going to count for 1 full minute, and you can use an alcohol pad. Now, the reason we use alcohol pads, guys, is because they're mystical, magical, and medical. Patients, if I put an alcohol pad on her tummy, are less likely to ask why. They just assume I need it for later. And if they do ask why, I can give them a nonsense answer like, I need that for later. And they'll go, okay. Right? They accept it. It's part of medicine. It's not really questioned. If I put anything else on her tummy, she's going to be like, what are you doing? Why is that there? What do you need that for? But alcohol pads, they're disposable. We can throw them away. They're cheap. But patients tend to tolerate them, and they don't interfere with breathing. Now, what some people will do for respirations, and I don't like this, but what some people will do is this, to feel their breathing while they're taking. This is intrusive. How comfortable is this, right? It's a little weird, isn't it? Right? So if you put your hand on somebody's tummy to feel their breathing, it's a little intimate. The other problem with it is that the weight of my hand pressing down can actually inhibit her breathing. So that's not best practice. The best practice is to use an alcohol pad to visualize it a little bit better. Good? Questions? So I'm going to do this whole skill beginning to end with the opening, washing my hands, the closing, washing my hands, and documenting. So I'm going to do this whole skill beginning to end. I am going to put an alcohol pad on her tummy. And when I look at that clock and I say start out loud, then you guys in your heads quietly count her respirations. When I say stop out loud, stop counting. And then I'll write down my reading, and we'll see how close you and I got. Okay? Let me just get a pen. Hold on. Can't believe I'm a nurse without a pen in my pocket. All right. Here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to take your vital signs. Is that okay? All right. I'm going to go close your curtain, wash my hands, get my supplies, and I'll be right back. So I've closed the curtain. I'm going to go wash my hands. So I'm coming over here to the sink. I'm going to turn the water on so it's comfortable. Wet my hands. Get lots of soap. Bring them together and look at the clock. I'm going to rub the tops of my wrists, the backs of my hands, in between my fingers, in between my thumb and index finger, that webbing area, the bottom of my hand by my pinky, and the palm of my hand interlacing my fingers again. So that is 20 seconds. Now I'm going to go down each one of my nails with my thumb to get my cuticles clean. I'm going to circle my nails on the palm of my hand to clean under, and then I'm going to rinse. When I'm rinsing, I don't want to touch the sink or the faucet. And then I'm going to tap to keep the water in the sink. I'll get whatever paper towels I need to dry my hands, but I only want to dry what's clean, not what's wet, what's clean. Once I dry my hands, I'll throw that away. Clean dry paper towel to turn the faucet off. All right, Miss Jones, this is going to take me about a minute. I'll let you know when I'm done, but I will need you to remain quiet until then, okay? Just need to lay that there. Let me have your wrist. Everybody good? Ready? Start. Stop. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Environment's clean. Bed is in the low position. Your call light is right there. If you need anything, just press that red button. I'm going to open the curtain and go wash my hands. So over here at the sink, I'm going to turn the water on until it's comfortable. Wet my hands, get lots of soap, rub them together, look at the clock. I'm going to rub the tops of the wrists, the backs of the hands, in between the fingers, in between the thumb and index finger, the bottom of my hand by my pinky, the palm of my hand in between my fingers, and that is 20 seconds. I'm going to go down each one of my nails with my thumb, circle my nails on the palm of my hand, making sure there's lots of bubbles, and then rinse, not touching the sink or the faucet. After rinsing, I'll tap, keep the water in the sink. Take whatever paper towels I need to clean my hand or to dry my hands, but I only want to dry what's clean. Clean dry paper towel to turn the faucet off. And then I'm going to document my reading. What'd you guys get? 13? Everybody get 13? Great job, because I got 13. So now I would tell the evaluator, my skill is done. Thank you. All right. Any questions? Any questions? All right, Miriam asked a question. Let me address this real quick. Do you have one-on-one classes or all your classes online? So I don't do one-on-one. I don't do tutoring, but we do have the replays of this. And all of you guys are enrolled in the online course as well. So my online course has all of these lessons broken down into small bite-sized pieces. Anybody do any of the online lessons yet? Anybody take a look at them? All of them have interactive activities, so it puts into practice what you're learning. If you really want to succeed on the test, make sure you're doing the online lessons as well, because it's really going to help cement in all of these concepts that I'm throwing at you. Okay, so that will help you. All right. Let's see here. All right. So now we're going to switch gears. Ooh, I am surprisingly close to on time. All right, we're going to switch gears. I'm going to go through the test registration process with you guys. Yes. So this is the front of the packet. You need this facing up when I hand these to you. Yeah, can you, oh, sorry. Here you go. Sorry, I didn't mean to miss one. There we go. Okay. All right, so everything I'm going to tell you is on my website. So if you go to foryourcna.com, under the testing menu, I've got test registration instructions. So if you zone out or you miss anything that I say or you can't remember something, remember that the instructions are here on my website as well. I actually do an entire registration with you on the screen. So I go through from the very beginning, like a Google page, show you exactly where to go, what to click, what to do. All of that is covered. All right, so this is the first page of your packet. It's what you see online here or on the screen here. These are the steps of registration. There's 4 steps to this process. They have to be done in order. The order counts. The first thing that you need to do is get a level 2 photo-enabled background check. Some of you may already have one if you work in healthcare. But just because you have a background check doesn't mean that it's going to meet this criteria. So level 2 photo-enabled for healthcare. So if you've got your concealed carry, that doesn't count. They can't find it. If you're a foster parent, that doesn't count. They can't find it. If you're working in banking, that doesn't count. They can't find it. It's got to be in healthcare. So if you don't have a background check, you're going to need to get one. That's step 1. I'm going to go through that process in just a minute. If you have a level 2 background check, photo enabled, you're working in healthcare, you know that that's, it's within the last 5 years, you know that that is covered, then you can skip to step 2. But if you just do the registration without the background check and they can't find the background check when they go to look for it, it's going to add about 2 weeks to your processing time. Okay. So it's going to take longer to get your test date. Just keep that in mind. So we're going to get our background check. We're going to fill out our registration packets and submit them either online or by mail. And then we're going to wait 1 to 3 days after we do our registration. We're going to get an email back from Prometric. We're going to open that email and look at the attachment. Now the attachment, let me pull this up. When you open the attachment, this is what it's going to look like. This is what the attachment looks like. And there's 2 boxes that you have to pay attention to. It's the 3rd box down will say application status. If that says incomplete, you need to contact Prometric and find out why. Either your payment didn't go through, or they didn't find your background check, or there's a problem with your name or email. So if it says incomplete, you need to contact them. Most of the time, it'll say complete. And then way down here, you'll see FBI background status. It should say record found. That means that they looked in the clearinghouse, they found your background check, they put it with your application, you're good to go. Below that, it's going to say pending approval. So let me explain to you what this process looks like on the other end. the processing in, because I think it helps you understand the whole big picture. Okay. When you register for the test and you send Prometric your registration, Prometric takes your registration, they go find your background check in the clearinghouse and they put it together. And then they send it to the Board of Nursing. The Board of Nursing has to look at every application and every background check to make sure you're safe to work with grandma. This is a human process. This is not automated. So they look at your registration and your background check and make sure that the two match exactly and that you're safe to work with grandma. Once they look at that and they make that determination, then they send back to Prometric, this person is good to go, approved to test. When that happens, you're going to get another email from Prometric. It'll look just like this, except down here, it'll say approved. Instead of pending approval, it will say approved. So that means that your stuff went to the Board of Nursing, they approved it, they sent it back to Prometric. So now you're going to wait. It takes about 7 to 10 days, this whole process. You're going to get a third email, usually about 1 to 3 days later, from Prometric. It says, hey, here's your test date. So you register, they find your background check, they send it to the Board of Nursing. The Board of Nursing approves you, sends it back to Prometric. Prometric gives you a test date. They don't give you a lot of warning. So when you get your test date, you'll be testing usually about a week later. They don't give you a lot of warning. But if you get your test date and it says October 14th, and you know you absolutely cannot, under any circumstances, make that test date, you need to call up Prometric and say, hey, October 14th does not work for me. And while they're on the phone with you, they will find a mutually agreeable date. But they don't take requests right off the bat. They will issue you a date. Now, if you wait until October 13th to call them and say, hey, I can't make it tomorrow, they're going to charge you because they can't put anybody else in that spot. You took a spot that you're not going to use, but it's too late to assign it to somebody else. So they're going to charge you for that. So when you get your test date, if it doesn't work, you need to let them know right away, immediately, so that you don't get charged to switch. Good? Questions? All right. So there's a couple of things on this sheet that I want to bring your attention to. This third line here is highlighted in gray. Do you guys see that? That means everything on that line is important. If you don't pay attention to anything else on here, pay attention to that line because everything on that line is important. I also want to bring your attention to the word important at the bottom that says you must select E3 Challenger as a testing option. Any other selection will prevent you from testing. It's on the paper. I talk about it. We're going to review it again at the end. And every class, I have somebody that calls me up and says, they're asking for a school code for me. If they're asking for a school code, you did not select E3 Challenger. What are you going to select? E3 Challenger. If you select anything else, you're not going to be tested because they want a school code. I can't give them a school code. A school code means that we went into a nursing home and worked on live humans, and we did not. So I can't give them what they're asking for because you did not meet that criteria. Okay? So we have to register as a challenger. Anything else will prevent you from testing. So not only is it here in the gray box, it is also here in bold letters. All right, so let's learn how to do this. So if we need to get a background check, I'm going to go through these steps with you just so that you know. I'm going to pull this over here. So you know how to find all of this. And again, you'll have the replay of this. You can go through. Remember, it's always class 4. It is always the last hour of class 4 that you can review all of the steps of the test registration. So you have all of this to review. But I want to go through all these steps with you very quickly so you're familiar with the process. So if you need a background check, we're going to go to prometric.com/nurseaid/FL. This is Prometric's website, the testing agency. And we're going to go down to candidate resources. So when you go to Prometric's website, all of these accordion things are closed. We're going to click on candidate resources, and this is going to open up. And then we're going to go down here to FL for Florida, DOH, Department of Health, fingerprint vendor list. And it's going to, if you click on that, it takes you to all of the people that are approved to do the level 2 background checks for our industry. And it's a very, very, very long list. Very long list. This is the cheapest. How many of you guys like less money? Yeah, me too. This is the cheapest. There are some that are a little more convenient for you, but Deontis is by far the least expensive. I had a lady that wanted to come in here and fingerprint, the class. It's convenient, right? She comes in, she does all the fingerprints and everything, but she was charging about $120 a person. So this is cheaper. All right, this is about $76. So a lot cheaper. All right, so if you go to Deontis.com, they actually changed their website, but if you go to Deontis.com, it'll take you to the right place. I've got to update the slide. So Deontis.com, this Deontis uses UPS stores, but only select UPS stores, not all of them. So when we go here, we're going to click here, create an account, or here, register. Either one of those links will bring up this page. We have to create an account on Deontis. They got to know who we are, right? If we're going to get a background check, they got to know who we are. So the first thing we're going to do is put in our email, select our password, check the boxes, and hit create an account. When you do that, they're going to send you an email. You have to go to your email, click the link to, prove that that email is yours. 2-factor authentication. So once you do that, it's going to take you back to Deontis, right? Now they know that that is your email. You've got an account. You're going to go back to Deontis, and you're going to have to log in. So make sure you remember that password, guys. Write it down. You're going to log in. When you log in, this is where it gets really confusing, because I had to do this like 3 times to figure out what to click. And I teach for a living. I teach this for a living. So these steps are going to be pretty important for you to review. The first thing you're going to do is select Florida services. It's not double check. We need Florida because CNA is Florida based. Florida services. When you check that, you're going to need an ORI number. This page, first column, gray box. Remember, everything important is in gray. Gray box, there is an ORI number. You're going to need that to register for your background check. So, ORI number, EDOH0380Z. And we're going to put that ORI number in the box that comes up. When you click Florida Services, this is the page you get to. We're going to put our ORI number in there. When you click Submit or Verify, it's going to bring up, okay, well, that code is CNA by exam. Is that the one you wanted? Yes, that's the one we want. So we're going to hit Next. If it says anything other than CNA by exam, hit that back button. You're going to have to do it again. It's going to take you to this page. And this is where it really gets like, well, I don't know what to choose here. I don't know what goes in these boxes. So again, you'll probably have to review this. Remember, it's class 4 last hour, and it'll go through all of this with you. But the first thing that you're going to see here is reason for request. And there's a couple of different options here. We want the last one, other employment and licensing, because that's what we're getting is licensing. When you click that, it's going to ask you for an OCA number. That does not apply to us. That's an employer number. We're not actually doing this for employment. We're doing it for licensing. So we're going to skip that. Skip our OCA number. And then it's going to ask you for your specific information. your name, your address, your phone number, your social security number, all of that stuff, right? What makes you you. Once you get done filling all of that out, it's going to take you to this page asking you to select a fingerprint processing center. Now, for us here in Spring Hill, it'll have you put in your zip code. It'll bring up the ones closest to you. In Spring Hill, ours is going to be on Barclay. It's the UPS store on Barclay by the Parkway. Okay, UPS store on Barclay. Now, if you're up in Citrus, there's one in Lecanto. So you're going to want to put your zip code in and find the one closest to you. And then once you do that, it's going to take you to a calendar. You can select your date and your time that you want to do the background check. Usually you can get in same day. So it's not like, like a 3-week wait to get your back. You can usually, if you do this in the morning, same day appointments. So select when you want to get your background check. The whole process takes about 10 minutes. It's going to be a picture, a signature, and digital fingerprints. So they don't actually ink you up. It's all digital now. Once you do that, it's going to take you to the payment page. It's going to tell you how much it is. $76.68 is the price as of when I created this. I don't think they've gone up. And then it's going to ask you, how do you want to pay? So you'll enter your credit card information. And then they're going to send you an email with all of that appointment information, and you now have a background check appointment. Go do that. Once you've done your background check, they're not going to give you anything to take anywhere or send anywhere. There's something called chain of custody. Almost everybody has the ability to change a background check using nothing more than your cell phone. So we can't have you have access to your background check. So it's going to be electronically transmitted. You aren't going to get anything from the fingerprint place. They're just going to do your fingerprints and picture, and they're going to send it where it needs to go. That's why you needed that ORI number. So you're not going to get anything. You're just going to go home. About 24 hours later, you can register for the test. That's all it takes. About 24 hours, you can register for the test. All right. So when you go, they're going to take your fingerprints, photo, and signature, and then they're going to transmit that for you. Once you're ready to register for the test, we're going back to prometric.com/nurseaid/FL. It's on this sheet. It's on here under step 2. And when we go there this time, we're going to click on something different. You can mail this in. This is the registration paperwork. We're going to go through this in class today because the online is exactly the same as this. So we're going to fill this out together in here so you know what to put where if you're going to do it online. Okay. Or you can just mail this in. Good? Okay. If you want to do it by mail, the address is there. This is important. Important to note. On the sidebar, they have an area that says contact us. They didn't used to do this. They used to hide their phone number so you couldn't call them. They're sneaky. But now they've been made to publish their phone number. And I want you to know where to find it. So you'll see it on the sidebar there. It's 888-277-3500. I also have it on here for you, because chances are one of you is going to have to call. When we do this, when we do the test registration, right here on their website, it states, if it has been more than 5 business days since you submitted an application and you have not received confirmation, please reach out to us. So if you put your application in and you don't get any emails back from them within 5 business days, what do they tell you to do? Call. Yeah, they used to tell you that, but they wouldn't give you their phone number. So now they have to give you their phone number. But when you call, very important, do not talk to the person that picks up the phone. The person that picks up the phone is a minimum wage employee that has one job: get you to hang up. So they're going to tell you things like, oh, it can take 90 days to process your registration, or no, it hasn't been long enough yet, or they're going to give you a whole bunch of nonsense excuses. They do not know your account. They have no access to your account. They're giving you stock answers because what is their job? To get you to hang up. So your answer to that, don't call me going, oh my gosh, they said 90 days. Yeah, no. Your answer is, on the website, it says that if I don't receive a confirmation in 5, you read this to them. Read this to them. And then say, I want a supervisor. And they will get you a supervisor. And that's the person that can look into your account. Let me tell you why this is important. I had a student who did not do this. Registered for the test, never heard anything back. They took the money out of her account. And 3 months later, she comes to me and says, hey, they took my money, but they never gave me a test date. Well, did you get any emails from them? No, I didn't get any emails, but I never got a test date. So I had a call while she was with me, and they had her email address in wrong. There was a typo in her email address. So all of the emails that they sent her did not get to her. Her test date had come and gone, and they did not give a refund. Because they said, it says that you're supposed to call us within 5 days if there's a problem. You didn't call us, not our fault. I don't know about you, but I don't have an extra $155 just laying around that I can give to Prometric. So take this seriously. Problems will come up now and then. So you need to know the process and how to fix it. Okay. All right, so once we get into Prometric, we're going to go to application process. There's 2 links here. There's one for the online application form, and there's one for the paper. This is the paper. I printed it off for you. This is it. Online is exactly the same except for one change that we're going to talk about at the end. One difference. All right, so we're going to look at the paper application. And that is this page. Paper application. Before we get there, though, I want to talk to you about these 2 pages here. These are the testing centers in Florida. These are the testing sites that we can go to. I've broken them down into regions for you so you know about where, you might want to go to test. For us here in this county, our closest one is in Tampa, and it's Gillis. So you might want to put a star next to the last one on the first page. That is our closest one. So on the bottom of the first page here, the bottom right here, Gillis, this is our closest. Now, those of you in Citrus, you might want to test up in Ocala. There are a few in Ocala, too. You would want to look at those. But you want to find the one that's closest to you that you want to test at. We're going to need that code in a little while. The code right in front, it says CNA-TAMAIR. Do you guys see that code? We're going to need that in a little bit. Well, let's go to the actual registration form. This is what it looks like. First thing you see is a stop sign. It says, please make sure your name is, in fact, your name. You need 2 forms of ID, one with a picture, non-expired, government issued, and one with a signature. It can be a debit card, credit card, social security card, library card, something that has your name and signature on it. 2 forms of ID, they must match. Down below that, it's going to ask you if you need ADA accommodations. This is, do you need a sign language interpreter, a seeing eye dog, whatever. There's a whole packet that you have to print off if you want ADA accommodations and take it to your doctor and have them fill it out. Below that is candidate information. So it asks, have you taken the CNA exam since 2002? You're going to answer yes or no. It's going to ask for your name. Remember that your name that you put on here has to match your photo ID and secondary ID. Some of you in here, I think I have like 3 or 4 of you that have multiple names. You're going to look at your ID, your photo ID, and whatever is on your photo ID is what you're going to put here. Now, this is a little complex because if you notice, they only want your middle initial. So if you have 4 names, if you have a first name, a middle name, and then 2 last names, you're going to put your first name, your middle initial, and your 2 last names. If it's hyphenated on your photo ID, you're going to hyphenate it on here. If it's not hyphenated, leave a space. Okay, good. I know it's a little complex, but they've got to make sure that you are you. We had a problem down in Miami a couple of years ago. A woman was taking CNA exams for other people. They were paying her, and she would take the exam for them. So they've got to make sure that you are, in fact, you. Okay. Next page. Yep, let me go back through here. Next page are the rest of your demographic details. So your date of birth, your address, your sex. And the very last part here, it says you have a high school diploma or equivalent. If you're 18 years of age or older, check the box, yes or no, doesn't matter, but it doesn't matter. As long as you're 18 or older, you can test without a high school diploma. This only really counts if you're under 18. But they do use it for data gathering to see how many of, what age groups are testing. So they do use it for data gathering. Now, this section down here at the bottom of page 2, we have to talk about. This is not self-explanatory. These are criminal and Medicaid, Medicare fraud questions. What this means is that some of our doctors were convicted of committing Medicaid and Medicare fraud, which means that they billed for services that they did not provide. If you worked in that office and you were taught how to bill fraudulently, and they caught the doctor and they prosecuted, you would be on a list. You would have had to go to court too. You would be on a list of people that cannot work in medical because you know how to defraud the government. We're not going to let you do it again, but you would already know that you're on that list, right? It's a whole court proceedings. This isn't a surprise. So for the majority of you, the answer is going to be no. You've never been through any of that. This does not apply except for question 1 and 2. If you have a felony in your background, see me after class. If you have a felony in your background, see me after class. If you have no felonies in your background, the answer for number 1 is going to be no. Go ahead and check off no. But leave A, B, C, D, and E blank. Don't answer those. So we're going to check no for number 1, and we're going to leave everything else blank. We're going to go down to number 2 and check no. Turn the page and leave A and B blank. So if you have a felony, see me after class. Everybody else check no for 1 and 2. If we go to numbers 3, 4, and 5, this is that Medicaid, Medicare fraud situation. So if you've never worked for a doctor that committed fraud, they never took that right away from you in a court of law, your answer to 3, 4, and 5 is no. Leave A, B, C, D's, and all that blank. 3, 4, and 5 is no. Moving on to disciplinary history. Disciplinary history. If you've ever had a CNA or any other medical certification in Florida or any other state, you need to answer these. If you've never been a medical professional anywhere, your answer to all 4 is no. Let me explain to you what these questions are. They want to make sure you weren't a CNA up in Indiana, smacked around some old people, got your license taken away, and you thought you'd move to Florida and do it here. They will find out, but they're asking you to self-declare. Okay. Now, down to criminal history. This one's pretty easy. Either you have one or you don't. If the answer is maybe, it's probably yes. So you either have a criminal history or you don't. First one's asking, do you have a criminal history? Second one there is if you've ever had records expunged or sealed, that some lawyer told you that we'll never find it. You know, they'll bury it. Nobody will ever know. Yeah, they lied. We'll find it. And then the last one is a juvie record. Juvie records, people think that they aren't held against you. They may be, but you have to declare it. Don't lie on this. If you've got something to hide, they will find it. And if you lied, you will not be allowed to test. So be careful with this. This is the part that disqualifies most people that are disqualified for the test. Be honest, and they'll work with you. Try to hide it, and they'll disqualify you. Okay. Okay, going to the next page. This is at the top of page 4. This is your page. I cannot help you with page 4, so we're going to move on to page 5. Page 5. Remember I said that we're going to check off which one? E3 Challenger. If you've noticed, I've already done that for you. I've already checked off E3 Challenger for you. The next section, training information, I've got a big X through it because we only check that off if we check off E1 or E2. We did not. We checked E3. Therefore, this section does not apply to us. Moving down a little bit further, you see test site information. I've already checked off regional test site. Remember I said you're going to need that code for a Gillis? This is where you put the code in. Now, if you're doing the online registration, remember online is this exact form just on a computer screen. If you're doing the online registration, this is going to be a drop-down menu. It's going to list all of the testing locations. Just a Gillis is at the very top. Just click that one. And then down here, we have exam processing and fees. So most of you, not all, but most of you are going to be fine with the very first option there. Clinical skills and written, the written test, clinical skills in English, the written test in English. Okay. So for most of you, go here. No, we've already done that. Okay, so most of you, that first option is what you're going to choose. But if English is not your first language and you want the computer to read the test questions to you, or if you have a learning disability or a reading disability and you want the computer to read those questions to you, you can choose the second option where it says oral. That means that the written test questions will come up on the screen and a computer will read it to you through headphones. So you can either choose the first regular test, the second one with headphones for the written test. Now, there are a few other options down here. You can get the written test in Spanish if that helps anybody. So you can take the written test in Spanish. You can also have the computer read those written test questions to you in Spanish. So you have to decide, do you want the written test in English or Spanish? And do you want the computer to read it to you? So whatever you choose, you're going to check the box next to whatever you choose. And then off to the side here, you're going to put $155 because it doesn't matter which of those options you choose. It's all $155. And that's what you're going to pay to Prometric. Okay. Going on to the next page, right here, you have to check yes, that you have received these 2 pages on the very back of your packet. This is the FBI privacy statement. It says how they're going to use your personal information to clear you for testing. So you're going to check yes, that you have received that notice. You'll read your affidavit, sign and date, and then down at the bottom, let's talk about that. At the bottom, remember our website said if we don't get a confirmation that they received our registration within 5 business days to contact them? All right, down at the bottom of our registration, so we did our registration, we submitted it, we got an email back from them, good, so that doesn't apply. But down at the bottom here, it says if you do not receive your ATT, Your ATT is your authorization to test, your test date. If you don't receive that in 10 to 14 business days, contact them. So again, if you have to call Prometric, that person that answers the phone, you're going to tell them, this is what my application says. I need a supervisor. Good? I know they're going to call me one day and yell at me. All right. Any questions on that? Okay. So we should receive our authorization to test 10 to 14 business days. All right. And remember, this is your contact information. If you don't receive your confirmation of registration, or if you don't receive your test date, this is who you're going to contact. This is their email and their phone number. All right. When you get emails from Prometric, please make sure you open the attachments. The emails are generic. The attachments are specific to you. So open the attachments. All right. Your homework over the weekend is chapters 5 and 6. 5 is on dementia. Pay attention. You'll have a lot of dementia patients in your career. But chapter 6 is on skills, and we go over skills in class. So don't worry too much about chapter 6. I do want you to read the paragraphs in between the skills. And any skill that we aren't covering in class, you probably want to do a little quick review of. But we are covering in class all of the skills that are required on the state exam. Okay, good. Good. All right, so you will get a wrap-up email after class today. You can watch the replays. And remember, class 4, last hour is test registration stuff. That will help you on our main website, flcnatraining.com. On that website, on class 4, you will actually see the video for the test register, where I do a test registration on the screen. Everything that you need to complete this class is on that one page, flcnatraining.com. Okay. All right, so let me give you your review sheet. And then the rest of the class is available for practice. Does anybody have any questions for me?
I've never been doing stuff, so we can try it.
There you go. All right, for those of you who are joining us online, please remember that you do have access to these review sheets on flcnatraining.com. So you can review you can print off and complete any of the review sheets that we have in the class. And we will see you on Monday. Did anybody tune into the game show yesterday? Anybody tune into the game show? Okay. The replay is up on my YouTube channel. So if you go to youtube.com/foryourCNA, I have a whole playlist of those game shows. And there's I do 15. I've been doing them for a year. So I do 15 at a time. So there's like hundreds of questions in there that are good for practicing, getting ready for the test. But I totally lost where I was going with that. The playlist for your youtube.com/foryourCNA, and that'll bring up that playlist. Class will begin again at 9 a.m. on Monday. That will be week 3. So we're halfway done with class now. On week 4, I will also have a CPR class after class. So we'll teach 9 to 1, and then 2 to 6 will be another CPR class. So if you did not do CPR last week, you have one more chance on the final Monday to get it for 45. After that, it goes up to 55. Okay. All right. Until next time, guys, happy caregiving. Bye.